Dean County, Vice President of Policy of Cancer Support for Community, and it's true and privilege to welcome you to our 7th annual Utilization Management Summit. The Cancer Support Community for the Legal Potential for our Utilization Management Summit, which aims to do 3 things: advance awareness, education, and advocacy discussions around the effects of practices on patients and the healthcare system. The CSC team is so grateful for all of your participation and your ongoing work on behalf of the patient, caregiver, and survivor communities that you serve. And we want to thank you for being here because we know today is a very popular day in DC. And there are many places you could be, and we thank you for making the time to be here. And we want to thank you not just for your time, but for your commitment. Your presence underscores how urgent and important this work is. As we know, touches every point in a person's journey. And when it falls short, the consequences are real and personal. The summit for us is more than a forum. It's a moment to spark change. Together, we'll examine the challenges, but we'll also explore bold, collaborative solutions that center patients, support providers, and strengthen our healthcare system. So before we jump into our discussion, we want to remind everyone why we are here today. Our forum was created to do, as I mentioned, fostering thoughtful conversations that engage a broad range of healthcare stakeholders and keep the focus on patients and the cancer community that we serve. Ask tough and nuanced questions about when various approaches are acceptable and when they have the potential to harm patient health outcomes, as well as identifying new areas and promising practices that optimize evidence-based healthcare. At CSC, we are committed to fostering these conversations that inform and engage all stakeholders in the creation and implementation of strategies that include the patient perspective and incentivize cost efficiency through improved patient care and outcomes. In fact, leading up to this summit, we held a virtual roundtable discussion in April about how recent changes to prior authorization and formulary placement are impacting access to treatment in the areas of lung cancer and multiple myeloma. Our 4 panels today will focus on pressing issues related to utilization management policies. Our first panel will focus on centering the patient voice, defining experience in a changing healthcare landscape. And through this session, we're going to bring together leaders in advocacy, care navigation, and research to examine how patients experience today's healthcare system across conditions, communities, and coverage types. Panel 1 will be followed by supporting the whole patient, employer-based strategies for oncology and other chronic conditions, for a discussion on how whole person care, including oncology, nutrition, obesity management, and chronic disease prevention, is being prioritized within employer-sponsored health plans. Panel 3 will be on the cost of access, looking at copay assistance programs, policy shifts, the future of treatment affordability. In this panel, we will explore the intent and impact of the Help Copays Act and discuss potential implications of proposals to eliminate cost sharing for essential treatments. Last, but certainly not least, we'll wrap up our program with a panel on pharmacy benefit management reform. This conversation will break down current PBM reform efforts while examining the role of step therapy, prior authorization, and proposals or solutions aimed at improving transparency and accountability. So what I'd like to do is quickly go over how the program is going to run today. After every session, there will be a 5-minute break, with the exception of the end of panel 1. Following panel 1, we will have a 15-minute break so that you can grab your lunch. But as you can see in the back of the room, there will be coffee and refreshments that you can help yourself to at any time throughout the program. Bathrooms, this is a very important piece of information, are located outside this door here. If you make a right and just follow the hall around, you'll find the restrooms here. And we have information or signs with the Wi-Fi passcode if you're looking for that so that you can get to connected. I believe that's in the front of the rooms. You'll also see there are some QR codes that are placed on the table that will give you access to our briefing book, but you should have also received that in your Know Before You Go emails as well. And lastly, I'd like to say thank you to our sponsors, Bristol Myers Squibb, Johnson & Johnson, Merck, and Takeda Oncology for helping us fund the important work that we do. So let's listen with empathy, speak with clarity, and imagine what's possible. On behalf of the cancer support community, thank you so much for being part of this important work. And we really hope you leave today inspired, informed, and ready to keep pushing forward. So we're going to get started. So what I'd like to do is now switch to our first panel, where we're going to start off with a very powerful and timely panel discussion that promises to be both thought-provoking and deeply relevant. Together, we'll be exploring the complex intersections of utilization management and its impact on patient well-being, supporting broad access to care, and meaningful representation, particularly in the context of rare cancers, chronic conditions, and the broader non-medical drivers of health. We are incredibly fortunate to have a distinguished panel of experts to guide this very important conversation. And to get us started, it's my pleasure to introduce our moderator, who also serves as our Chief Executive Officer, Sally Werner. So please join me in welcoming Sally Werner and our exceptional panelists. Then mention Sally Werner. We have Kyle Amey, a cancer policy advocate and bereaved brother to a 20-year survivor. Dr. Stephanie Broadnax Broussard, Director of Social Work at Thyme Care. Dr. Brandy Farrar, Managing Director at the American Institutes for Research. And Dr. Lisa Fitzpatrick, Founder and CEO of Grapevine Health. Thank you all for being here. Let's dive into the conversation.
Thank you, Deneen, and welcome. So just to get us started this morning, I see a lot of familiar faces in the room. Many of us were just at ASCO together. So for those of you in the cancer space, welcome back. Good to see you again. But what you're really aware of coming out of ASCO is all of the amazing clinical transformation that is happening. We are also aware that it's difficult for patients and caregivers to keep up with that transformation, especially in the community setting. So today our panel is really going to get us centered on the patient or caregiver. So as we think about really access to care, affordability of care, quality as a theme, and research. And so with that, I'm going to ask each panelist a few questions so we can get centered on the patient voice. We'll have time at the end for questions, and then we'll listen to one final thought from each of our panelists. So I'm going to kick us off first with Kyle. Kyle, so tell us some of the flaws within our policy system that we need to work to fix to help cancer-affected families.
Thank you for the opportunity to be here, first of all. And I just want to frame a few things. First of all, I am not a cancer survivor. My sister was a 20-year cancer survivor until, unfortunately, we lost her 3 years ago to this month. So I'm not the person directly representing a cancer survivor experience. I imagine there are people in this room who do that. So I'm speaking from a caregiver experience, but that does span a long time. Carol was a cancer survivor. You're considered one on the first day that you're diagnosed, right? For 7,138 days. And we experienced quite a bit of excellence in medicine as well as flaws in medicine during that time. So from a policy perspective, when I think about policy from the affected family, cancer-affected family view, really, for me, I think the issue is in incentives, not just rules, right? So we are trying, the conversations we're having right now, whatever side of those you're on, and I imagine that everyone has an opinion, they're really about efficiency, right? Cost versus economic impact, and outcomes are sometimes considered and sometimes not considered. So I've worked on a few pieces of legislation so far. I intend to work on far more. And one of the first things that you get asked if you talk to legislators is, have you scored the bill? Which basically means, have you put a price on us passing this? And, the data around what happens if these people survive, what happens if they get the treatment that they need first, and then they go back into our society and they're able to work, and they're able to pay taxes, and they're able to pay insurance premiums. What does that revenue look like, right? So I don't like talking about it from a cold economic argument, but sometimes we have to do that if we're going to make progress. And so what we need to do when we're thinking policy is to think of ways to incentivize better partnership between medical institutions, universities and hospitals, and different systems to make it so that they're not competing against each other for the same dollar. They're not competing against each other for the same research outcome. They're not in silos studying the same thing, coming to the same conclusion that that didn't work, and spending 2 or 3 or 5 times as much money as they have to because they didn't tell their competitor about it. Another thing is access to care. And what do we mean when we say access? For us, it was that my sister, when she was about to turn 26, was no longer going to be able to be covered under private insurance, which my parents had been providing for her that entire time. So they had been worried for years, even when she was not fighting cancer. What if it comes back? What if we do not have coverage at that point and this becomes a pre-existing condition? Another thing is with medical decision making. There are bills out there, some of them cancer support community is working on, that cover genomic sequencing or molecular diagnostics, basically the test that at the outset of cancer diagnosis, we can determine what the best path forward might look like. If you extrapolate in the future, maybe we can use database tools, maybe we use AI to take a sample of cancer, of a tumor, whatever it is, and run through, this is your best chance of survival, this is your second best chance of survival, and not guess which drug is going to be the best opportunity just because pharmaceutical salesperson has arrived and asked the doctor to promise to write so many prescriptions of XYZ. So those are some of the things that I've been thinking about as it relates to policy, but open to a discussion, obviously. And thanks again for including us.
Thanks, Kyle. Really, really insightful. And we love the caregiver voice. Really important. I'm going to move to Stephanie. Stephanie, can you talk to us a little bit about how behavioral health needs impact a person's cancer journey? What are the risks, both clinical and personal, when those needs go unaddressed? And right behind that, what are some things we can do to address this changing healthcare landscape?
Thank you once again. Thank y'all for having me. I don't want to sound super social worky, but I can't help it. I'm a social worker. And I think the most important thing is that we have to understand that when we say we're treating a patient, we cannot forget about their emotional and mental well-being. Oftentimes, we are so focused on the statistical outcomes that will come with their pathway and their disease, but their emotional and mental well-being is part of that disease. The outcomes that affect them emotionally and mentally also should be considered in outcomes. So when we think about the needs of our patients, a lot of times we focus on, proactive assessment. A lot of times at ASCO, we're just talking about ePros and we're looking at what does it look like for proactive symptom management. But you're now doing a distress thermometer, but oftentimes people don't have access to the resources that are necessary if you have a positive distress thermometer. So you have positive distress thermometer, may need to have a PHQ-9 for depression to assess whether or not you have depression, or a GAD-7 to assess whether you have anxiety. But in most community oncology practices and even some academia or health systems, there is no one to follow up on that care. And we already have gaps in our society where they don't have access to psychiatrists, or there's a limit on the amount of therapists. And you add the nuance of cancer. There's very few clinical specialists who can provide access to behavioral support who understand oncology. I had a patient tell me, I love my therapist. I've been seeing them a long time and they're great, but I am so tired of explaining to them, this is my cancer, explaining what this means. So the fear is not my anxiety exacerbation. It is my fear of my skin. Skinxiety is a real thing. It's not an exacerbation of something that's new, or of my anxiety. It is a byproduct of my cancer. And so if we don't focus on the behavioral health components that come with this, ultimately we see people also their depression that comes with cancer, because the fear, the uncertainty, the sadness, the grief, right? I have survivors who tell me all the time that I feel this ambivalence. I'm so grateful that I'm alive, but I also grieve the life that I used to have. I don't know what to do with the symptom burden that I now have as a result of my treatment. And everyone wants me to just walk around happy and grateful. But I'm sad and I'm grieving. And so if we don't adequately provide the supports to address that behavioral health component, people have great outcomes, but then they're miserable and been dragging through life because no one prepared them and equipped them with the coping skills they needed to navigate that season. And so I believe that access to social determinants, that wasn't this question, but I got answers for that too. But I believe that access to social determinants of health and psycho-oncology or psychosocial emotional support for oncology patients is not supplemental care. If you look at any other, like let's look at end-stage renal disease, they have to have access to social work. You look at transplant, they have to have access to social work. They have to have an assessment to assess their emotional, mental well-being, and even their social determinants of health to be able to navigate the disease. Cancer, it is not a requirement, but we have just as much impact. And so I believe what we have to do is reframe how we look at this layer of support. We have to be able to say that this is not supplemental, but it's necessary. It's standard of care, which ASCO has done, right? To say this is standard of care, that people get access to number one, social determinants of health screening, but also distress thermometers and screenings that will help. But the addition, which we got really close to with OCM and EOM, we'll talk about that. I'm not going to talk about that, but we get really close, but we kind of shy away from the requirement that people have to have access to this kind of support. And so I believe that's not only a policy issue, but that's a standard of care issue. But that's also the stance that we have to take as the oncology community to say, how we provide the best care to take care of the whole patient. And that's from start, the day they're diagnosed, to end of life. Okay, I think I answered your question.
You did. And I always say that doing distress screening without resource referral and follow-up in itself is distressing. So thank you for that point. Okay, so Brandy, we'll shift to research for a moment and talk a little bit about what methods you have used to capture the patient experience of utilization management, and that you find particularly informative.
Yeah, I think my comments actually follow really nicely from yours, because I wanted to talk a little bit about human-centered design as a how. I think there is a lot of interest and support for really thinking about how do we center patients in care, right? And how do we center patients in policy? I think we're still newer in terms of how do we really do that, right? Like, what tactically do we do to make sure that policymakers have the information that they need to design systems that work for patients? And so I really think that human-centered design has a lot of value. And so I'm not going to get into the jargon because I am a researcher, but really thinking about how do we empathetically listen to patients and their experiences and characterize that in a way that's useful to a policymaker, a program designer, right? And so it's things like we ask people as they move along their journey, we do journey mapping, right? We want to know, tell us every single step in your process. What does it look like? What are the touch points along the way? We ask them, what are your highs? What are your lows in terms of how you feel? We explicitly ask these things, right? We also ask things like, what are your broader goals for your life, right? To zoom out, because people's conditions are just one part of their lives, right? If you have cancer, that's just one part of your life. And so we hear that often, that fits into a larger goal for what they want, for how they want to live. And so really doing that empathetic listening systematically across different experiences gives us an opportunity to really depict that in a way that a policymaker can pick up. So we create these visuals, journey maps that someone could look at and say, oh, this person really, typically patients in our system or in our health plan commonly have this issue at this point of the process. And this is how they feel. And so they can look at that and design a different approach. Another thing that we do is we work with research participants to co-design solutions. So that's part of the HCD process. So it's not just us saying, okay, here's the issue, let's fix it this way. You say, well, what do you think would be the best way to fix this? Right. And so we engage them not just in sharing their experiences and identifying what the problems are, but in providing what the solutions are. And I think those types of tactics and strategies are really what we need to move the needle forward in a way that really is patient centered, because we have a lot of information about what the problems are, right? And what, we know all of the horror stories, and we understand that. But what if we gave that information to policymakers, to program designers, when they're making these decisions in a way that really has that tactical level of detail, that they can say, this is the lever that we can pull to really have a better patient experience.
That is great. Thanks, Brandy. I think that some of the recent opportunities to talk to the FDA, ODAC, what we're hearing is that research coupled with patient stories, caregiver stories, it's what's making an impact. So we definitely appreciate everything that you're doing. Lisa, let's talk about, why does health literacy and health communication matter in all of this?
Good morning, everybody. I'm looking forward to the second half of this panel when we hear what's on your mind. So get your questions ready, please. It's nice to be here to talk about health literacy. But before I start, I want to follow up on something Dr. Brandy said, which is their practice is to ask people how they think the problem should be solved. Now, this sounds pretty obvious, but it's not happening. And when it does happen, the information received is not implemented. Why is that? I've worked across the healthcare system, but the most striking experience I had with this issue is with a hospital CEO who told me the reason he didn't want to go out into the community with us was because once he heard all of those suggestions, people would expect him to implement them. And I think he's not alone. This is happening across research. It's happening in pharma, biotech. It's happening across the healthcare ecosystem. And we have to fight to get people to really take this seriously and say, we really do not just, walk the walk, not just talk the talk about listening to people. People know they need to listen. It's about what you do with the information. So I really appreciate you raising that. And so, I'm just starting to talk, but I'm already giving you a call to action. And that is, talk to people, whether they're your superiors or whether you're the one who's in the seat at the top of the organization. Make a decision that we have to implement what people are telling us. We can't keep having these circular conversations over and over and over again. So thank you for raising it. Health literacy. Why is health literacy and communication important? I'm sure all of you have a story. I did a TEDx talk a few years ago, and my first question was, raise your hand if you've ever had a doctor say something you didn't understand. 90% of the hands went up. So people understand this intuitively, that we have to speak in plain language. But it's not happening because we're so used to talking to each other, whether it's research jargon, medical jargon. And so how do we adopt plain language as a value? And I'll share a couple of stories related to this. One, my father is a cancer survivor. He was in the hospital recently. And his doctor is from India, first generation American. He came here to train as a resident, and now he's the attending. So my father, who grew up in Mississippi and has an 8th grade education, could not understand his doctor. So the doctor would come in the room and explain, okay, here's what's happening today. And I would just sit there listening, watching the interaction. So when the doctor left, I said, okay, so what's the plan today? He says, I don't know. I was hoping you could tell me. And I said, well, why didn't you ask? He said, I didn't understand anything he said. I didn't even know how to ask a question. I hear this over and over and over again. We have to be held accountable to make sure people understand what we're saying, which leads to my second story. My neighbor, who has heart disease. And I hadn't seen him for a while. And when I finally saw him out on the street, I said, "Where have you been?" He said, I was in the hospital." And I said, "Oh, are you okay?" He says, "I'm fine. They're trying to tell me something's wrong with my heart, but look at me. I feel good." And I said, "Well, why did you go to the hospital in the first place?" And he said, "Well, I couldn't breathe." So I said, "Well, when you were in the hospital, didn't someone explain to you why your trouble breathing was linked to your heart?" He says, "I don't know. They always use those big words and they try to confuse you so they can pump you full of medicine." And I said, "Well, where is the medicine now? Are you taking it?" He goes, "Oh no, it's stacked up in my cabinet. They keep giving me all this medicine because I guess they need to make money." So this is sort of the moral of the story, the distrust, because we are not explaining information in the way people need the information. So I focus on health literacy. I've been focused on health literacy for many years. My company is called Grapevine Health because this is where people get their health information. Especially today, TikTok and Instagram are way more powerful communicators about health than physicians are. And I'm sad about that. So I'm going to stop talking. I can tell stories all day long, but I think it's obvious to everyone that we have to communicate in plain language to build trust, which then leads to better engagement. Whether it's research, your own clinical care, prevention, it's all roads lead back to health literacy.
Thank you, Lisa. I think it's just critical when we talk about value-based care from the patient perspective. If they don't understand the care or believe in the care, there's no value.
But we're not funding that. It's a check the box exercise, whether it's pharma, whether it's biotech and research, whether it's health systems, health literacy is not a priority.
Okay, fine. Here is the $1 million question. I know you have the answer. In this really difficult and fast-paced geopolitical environment, how do we stay motivated to push for change, even when we feel overwhelmed?
I bet everyone has already thought about this week. Here's my thought on it. The hardest part about a cancer experience, and really probably any major medical experience, is the sensation of feeling completely alone. Even if you have a family around you that is as strong as it can be, your sense of duty, either as the patient or as whatever member of the family that you are, to show up for each other and not to show vulnerability, not to show weakness, is profound. My sister was incredibly brave. And when I say brave, I don't mean that in a platitude way. I mean, it's okay to be scared, but it's the way you treat the people around you that really impacts your outcome, right? It impacts who you are and the way that you're thought of. So I do want to tell a story about her. And I know everyone is thinking of their own folks, but Kara was in a radiation treatment in Boston. This was her 19th year as a cancer survivor. She was dealing with a very serious brain tumor, astrocytoma, for those that know the diagnosis. And we were waiting to receive radiation treatment at Dana-Farber Institute in Boston. And she saw another patient, an older man, who was there with his wife. And clearly it was his first radiation treatment ever. And he went in, and his wife broke down crying immediately after the door closed. And my sister, who was waiting for her own radiation treatment that's going to happen in like 10 minutes, gets up, goes over and hugs the woman and tells her, "I'm a 5-time cancer survivor. You're going to be okay." And the empathy overtook her. And so, I mean, that's a brave thing to do. She stopped thinking about herself and she started thinking about others. And it made me think about, we have different outcomes, right? Those of us that have experienced cancer, maybe the person that we know was okay, maybe they weren't. But if we draw a wider circle around ourselves and realize we're on the same team here, that's where the sense of community comes. And so organizations like Cancer Support Community, or Kara used to attend something called Camp Fantastic, which maybe you've heard of in this region. We're doing it for each other. And if we feel at this moment that, we're overwhelmed, that makes sense. But the people that have fought cancer didn't have a choice, right? They can feel overwhelmed, but they still have to deal with the consequences. And the thing about cancer is that it doesn't respect borders and it doesn't care about politics or beliefs. It is a problem for everyone. So if we don't get together and we don't, look for solutions, then we are doing wrong by the people that we've lost, and we're doing wrong by the people that have fought and survived as well. And who knows who could be affected by this in the future. So it's really about drawing that wider circle. And, if we feel helpless right now, I don't think cutting NIH by 37% is a good idea. I think that's not good. But if, we feel hopeless right now, we still maybe are feeling a glimpse of what it's like to actually be diagnosed with cancer and have no choice but to fight and move forward without the resources that we think we need. So I'll stop there.
That's great. Extremely grounding as we move into the rest of today, Kyle. So thank you so much. Stephanie, I'm hoping you can share an example that illustrates how interdisciplinary support models our patients during their cancer journey and help them navigate these complex decisions or barriers to care.
Yeah, so I think let me preface this by saying this may sound a little bit like a commercial, but it's not. It's really what I believe in. So I just want to preface that. So I work for Thyme Care, and one of the things that we've done is try to figure out how to bring interdisciplinary care to the patient when there's gaps. One of the things I said, and I saw Kawana's face when I said it, was that we are a group of people who came together to figure out how to be what we wanted to see when we were in the community providing cancer care. And so what we've done is try to look at this interdisciplinary approach. We believe that patients need access to all layers of care. So they need access to a good provider, but they also need access while they're having their cancer care with their primary care provider. They also need access to a nurse that can help them understand and navigate and break things down to a way that they can understand. Because health literacy is a major component when we think about outcomes. There are several studies that show people disengage with their cancer treatment due to lack of understanding, right? Not unexpected symptom burden, uncertainties. But if we can bridge that gap, it improves outcomes. But then also access to social work that can address social determinants of health, adequate assessment prior to cancer, because people come to us with the problems that they are already experiencing. So cancer doesn't just everything stop because cancer's here. Life continues. So how do we address those practical needs that people have? But then also access to behavioral support, making sure that we're adequately assessing and treating those things as they come. But then an additional component, which I think is really impactful, is we call them care partners, but access to community health workers. People who speak the language that they speak can communicate what the things are that are important to them in a way where there isn't this hierarchy in the medical community, or they say, I see you. We all try to say we do that. We try to see patients first and meet them where they are. But I think there's still a power differential that happens. And so it's really impactful when people can just speak to lay people and say, how you doing? Somebody to check in and be present with you. And so I think the first thing that I think is really important, I said this earlier though, is for us to make an interdisciplinary model standard of care. And it's really hard in a fee-for-service environment. I came from community oncology before going to Thyme Care, and we were one of the largest community oncology practices in the country. I managed social work. I directed social work and palliative care. I had 27 social workers for 232 sites of service. So there's a vast amount of patients who were not able to get social work support. But if you think about the places that do it really well, even they have gaps because they're reactive versus proactive management, right? Proactive response to practical needs. It is hard to do it in this fee-for-service environment. And so when we think about value-based care, I think the most important thing is that we have to show and demonstrate, which I hope all of us can come together because I believe it's a payer problem. I believe it's a policy problem. It's a clinician problem, is that interdisciplinary care, although may cost more upfront, ultimately improves outcomes and can impact utilization. When people have access to support to address their practical barriers like transportation and the things that impact their ability to maintain that treatment, they're more consistent. Sometimes we think about their ACEs or their adverse events, right, that impact people and how they show up in our health systems. If we are proactively able to support and address, we can't be everything to everybody. So that doesn't mean the oncology practice has to then now provide access to all kinds of support. It means partnering with the people in the communities that do what they do well, and us coming together on a united front to address the needs of our communities. And so that means sometimes vetting and partnering with places like cancer support community in the clubhouses in the communities that our members live in. I can't go to their community, but I can make sure that they're plugged into the people that do those services well, or making sure that they know where the food banks are, and maybe having a partnership and identifying them and saying, hey, proactively, we have members in your community. We need a food box to be able to send to them. Can you tell us these are the things we'd like to have in it? How much would that cost us? How do we partner with that? And sometimes they're already seeking out these people, so we don't even have to finance it. And so, but that requires conversations and community. That requires us to come together. Nobody's stance in the battle is greater than the other. So whether you're the payer, whether you're the provider, whether you're the policymaker, nobody wants to win. If anybody's losing in this, we all lose. Because if we can't pay for the care, then the patients don't get the care they need. If the practice can't be paid, then the patients don't get the care they need. Patients can get access to the care, the patients don't get the care that they need. So ultimately, if we don't come together in a multidisciplinary, which includes everyone outside and inside the practice or inside the community that's providing this cancer care, patients lose. And so I believe how we start to do that, first of all, is opportunities like this, where we come together and unify, whether it's research, all the areas, and everybody has a seat at the table. Because if we miss one seat, then we lose something in the conversation. And then also, I think it requires us to, Kyle said something that was really interesting, is that trying to make sure that when it comes to policy, that we are open when it comes to research, sharing our wins and our losses. Oftentimes we're losing because we're all trying to fight the battle, but somebody's getting to something first, but we won't share the information of who's coming behind us because we're afraid of what that looks like, right? They're our competitor. But ultimately, the patient loses. And so I think this kind of conversation where we center the patient voice and we all sit at the round table and figure out, how does my portion impact the outcome? And how can I help you impact your outcome? So that ultimately it pushes cancer care forward is really how we do it.
Thank you, thank you. You are speaking my language. I always feel like there are so many resources that if only patients knew about them at the right time, and not too late in their journey, what a tremendous impact we could have. So we're gonna kind of start on the end with Lisa here and give you each one final thought, and then we'll open it up to the audience for questions. So Lisa, give us your parting thought on patient-centered voice here.
There's so many things to react to, and what you were just saying. So I just want to encourage all of us to go back to our organizations and be the person who's pushing to say, we don't need to keep talking about this thing. We already know about this. We've talked about this ad nauseum. So what is the next step? Even if it's a small step, to do something different so that you're not going back to, how many of you went to ASCO this year and didn't hear really anything new? Maybe you heard some new science, but about these topics, did you hear anything new? So be that person who says, okay, let's move forward and do something to help people within our organization. Sorry, one more thing, the collaborative piece, that's hard because we work in silos. So you can also be that person who says, how do we become more collaborative and less guarded with our information? It's a really hard thing, but this is why we have inertia, because we all have to activate and decide we're going to be the person who speaks up and says, this is going to change.
Thank you. Okay, Brandy, give us your final thought.
Yeah, I think I have a similar final thought. I've been doing this. I'm a qualitative researcher. I've been doing this for probably 20 years. I talk to thousands and thousands of patients, consumers, it depends on the context. And I hear the same thing. I tell people, I can already tell it, I can write this report before we even start this study. They don't give a cigarette inside of it. But the themes are remarkably similar. There's some variation across different experiences for sure, different characteristics, different coverage types. I do a lot of work with people who are trying to navigate their health insurance to get the care they need. So we do see some variation across what types of plans, et cetera, but it's the same things that come up. We know that people need access to care providers that they trust and that they have been seeing for a long time. We know that people care about costs, that's all costs, right? Not just co-pays, co-insurance, but medication, which I know there's a panel later. We know that non-medical drivers of health are huge. I think we still underestimate how much that impacts people's ability to stay in care. Those are the three, right? If I could sum it up, the big issues. I think now what do we do in terms of translating that into change? And so I think it really is getting working directly with plans. We work with plans, we work with health systems, we work with policymakers at the state and federal level, and we get in there and we give them very concrete, tactical solutions. We do that negotiating. You know, I think your opening remarks were really, again, some people don't like to have those conversations, but those are the conversations that I think you have to get movement on these issues. And so I would also just encourage folks to push for the changes that we know need to happen, and to use the data and the evidence to do that. We do hear people are responsive to data and research. Sometimes they say a story is just a story, right? And we hear that. And so we really try to focus on, you know, delivering data and evidence to also encourage people to really take this seriously and make the changes that we know are valuable.
And I think that a story is just a story that's so impactful sometimes when you tie that end of one to the end of thousands. Right. Okay, Stephanie, your final thought in this patient-centered discussion.
I said a lot of words earlier, and I think I'll just let that be the culmination of nothing.
Now, we've been on for questions.
One more time. Here's what comes to mind. I think patients and patient families feel as though they're getting lip service about the support that they have when they go to a provider and they get excellent care at that one thing that they went there for. They get the test done correctly, they get the surgery, whatever it is. And then 2 hours later, they're on the phone with insurance arguing about whether or not that was medically necessary, that they just got that procedure done. And they're waiting for a call back from the doctor's office to schedule them for the next thing. And maybe the administrative person was at lunch when they tried, and it's 4 days there. And there's so many inefficiencies that aren't someone's fault within our existing system, but our existing system is inefficient. It isn't going to get the outcomes that we need. And we have the evidence of that, right? People are not surviving. My family had the ability to get essentially any care that was available. And we had a 20-year survivor, but ultimately ran into a cancer that we could not defeat. There's so many families that don't have the same access to care. And so it's not a fair experience for cancer patients. So we have to speak up for each other and realize this isn't just a business where knowing your customers and finding out their needs is going to create more profit, right? We have to seek outcomes as part of that conversation, not just the business element of it. I realize that has to be there too, but looking to patients and their families that have either survived or not survived, because if they're in treatment, they don't have time to express this to you. They're focused on that next thing and navigating that path. So as each family walks this path and determines where the potholes are, if they don't say something, then that pothole doesn't get filled in and the next person steps on it as well. So I have every respect for anyone who is a cancer survivor and chooses to go and then speak about their experience, or anyone who has lost someone and chooses to share that story in hopes that we can fill some of those potholes and ultimately create a path that is able to be traversed successfully.
Thank you for rounding us out. What an amazing panel. We are going to open it up to the audience for questions. So just as a reminder, health literacy research, patient navigation, caregiver, and advocacy perspectives. We'll open it up to all of them.
Pretty much summed it up. So it's like no big follow-up questions because you really sorry. I would just say you guys have summed this thing up really well because it's not a lot of follow-up questions because you gave the information. So some of the things that we know we experience a lot about the care coordination and things like that of patients. So you just hit it ham on the nail. So I appreciate each and every one.
What kind of organization are you in?
So I work at Midspot Washington Hospital Center. I'm a financial coordinator. And so I've been doing it for over 20-something years. So I help patients fight financial toxicity and things like that, benefits verification, things like that, just letting them understand what you all are saying up here.
So what do you think has to happen at your hospital for any of that to change?
I think more things need to happen. I think that some changes do need to go on because every system is flawed. I think that there are some innovative things that need to be put in place, such as a more.
I'm sorry, I know I put you on the spot.
Okay. I don't know if I want to say everything, put me in trouble, but I do think that there are some gaps in care. Even at my facility, there are some gaps in care, and I work with the cancer patients, and I think that it's missing some channels. I think it's missing some verification systems. I think it's missing a lot of in between before it gets to the patient and their care. So I think it's missing a whole lot of things. So but we do have a whole lot of things that also are resources for patients because where I work inside the patient cancer support services, we do have a lot of different connections. We have food connections. We have different partnerships with the community. We have different relationships with different grant philanthropy and things like that. We see the patient needs, so then we reach in and we hear what their needs. So we reaching out constantly trying to get these things in place at my facility. So I don't know what all facilities have, but I know in my facility, I'm working real hard to make sure our patients are at least getting those extra resources.
We appreciate that you're the person sitting in front of the patient helping navigate some of those challenges. Yes.
My name is Scott Willett. I'm with the industry Johnson & Johnson, and our focus is on policy and the access that can have patients. I realize this is a very general question, so yes, no. If you have any insights, I would love to hear them. But as we see CMS moving towards in 2030, this move to value-based care. Let me just say parenthetically, who's not for value-based care? I think the big question is, what does it mean? We see threats. Thank you so much for bringing the patient voice. We see threats to access in some of the structures of these value-based cares, specifically those that are total cost of care models. And just to be very blunt, we see them with not a lot of nice words and fluffy words, but it ends up being a cost squeeze. My question is, I would love to get your thoughts on how to make value-based care not run into the same issues that we overtly see right now with utilization management, if that makes sense. So welcome any thoughts in that regard.
Yeah, I can start us off at books. I do a lot of work in value-based care, working with the CMS models. And I think that's an excellent question. I know one path that people are pushing very hard for are having patient-reported outcome measures be a part of how these total cost of care models are being held accountable. So not just, related to cost savings and other types of clinical outcomes, which I think everybody on this panel agrees that clinical outcomes often overlook a lot about the patient experience. So I think that's one path that I think is promising. I think also sort of the auditing and the monitoring for these models, I think is also a critical component of it, so that there are protections around skipping and cherry picking of patients. That's a real and true thing that does happen that we see. And so I think really making sure that there are those auditing and those monitoring process is another way of and it's a backstop, right? So it's sort of after the fact, but at least she's starting to identify some of the most egregious sort of components, either of whatever the particular VBP approach is, or some actors who are implementing against. But I do think that there's also, I was thinking about in response to your comment to her question, systems are really hard to change. They're just really difficult to change, right? And that's what we love. We do a lot of work with providers as well to try to understand how they're implementing these models and other types of innovations. And so they're really difficult to change. But I do think that those sort of lines of accountability put them on the hook to think about how to change their systems in a way that are more efficient, that do work for patients. So I think I wouldn't write them off totally, but I do think there really does need to be a lot of attention to what it looks like to center patients in that, in those types of
Policymakers are people with families, and they need to be educated just like anybody else, even if it's Dr. Oz himself. I saw him speaking a couple weeks ago. There's a lot he doesn't know, and then he says he doesn't know, and he says, I want to hear. So the stories are really powerful. I mean, this is why people even know Medicare Advantage is a thing, because they started hearing stories about how people were unhappy and how their providers or their practices were getting too much money and they weren't getting the services. Why they're seeing the disconnect. So it's coming from voices from whether it's patients or from other stakeholders who are impacted by it. So I think because you are a pharmaceutical company, you have lots of extenders. Even if it's not you, you have patient advocacy councils, you have other groups that can also speak on your behalf and talk directly to the policymakers. There are a couple of requests for information on the street right now. So put this information in there. It doesn't have to be technical. It can be humanistic. It can be some of the stories we're talking about right now. It can be what you're concerned about, so that information gets on record and fed to the people who are going to read it. And I'm sure you're probably one person removed from someone like Dr. Oz or someone who's in charge of CMMI who can take this information and listen. And then the last thing I'll say is that the public has to get educated about how this stuff works, because they're the ones who have to advocate or threaten their congressional representatives. We're not going to vote for you if you don't do X, Y, and Z. And it can be as simple as that. People like plain, simple language to help them understand. We turn this into some sort of educational campaign to help people know this is how this will impact you. So you better raise your hand and speak up. Like, that's the age we're in now. The information is coming from the ground, putting pressure on people, and that the policymakers are no different.
I think sharing personal stories will impact policymakers on an individual level as they're voting for something, right? But there's also research studies out there that are actually measuring the impact of survival. And they're actually measuring the impact of, okay, what if we get these people back into society? And what if that person becomes a cancer researcher later on in their life? And there's so much that can be done to express the data that exists in a way that would, I think, lend itself to that model. So for sure on time, I'll yield there.
Thank you so much for your input. So it was a crucial demonstration.
Well, I just got the 2-minute warning, so we could wrap everything up. I just really want to thank this panel for all of their insights, for being vulnerable with us, and for starting off our summit today with patient and caregiver voice. And again, a focus on access, affordability, quality, and research as a society. Thank you.
So positive. All right. Going to
in the workplace, supporting the whole patient, employer-based strategies for oncology and other chronic conditions. As patient care continues to evolve, employers are playing a large role by looking beyond treatment for long-term running. Today's panel will examine how employer-sponsored plans are embracing whole person care from oncology, nutrition, obesity management, to chronic disease prevention. Our expert panel will share how benefit design, care communication, and strategic planning are helping to drive a better and more equitable care. Please join me in welcoming our moderator, Kimberly Pierce, Senior Vice President of Policy and External Affairs at National Health Council, along with our outstanding panelists, Melissa Bartlett, Senior Vice President of Health Policy for the ERISA Industry Committee, Dr. Millicent Gorham, CEO of the Alliance for Women's Health and Prevention, Andrea, Public Policy Manager for the National Coalition for Cancer Survivorship, and William Sorrell, Professor of Practice at the University of Maryland, Francis King Carey School of Law. Thank you to this distinguished group for lending your expertise to this critical conversation. Let's get started. Thank you.
Thank you so much. I'm Amey here. And 3 months ago, I joined the National Health Council. As Sabine said, it's my pleasure to be here. So nice to have all of our panelists know that we spent time pre-material for the read of all of their lives. I want to add that my father is currently managing living with age 4 melanoma and watching and helping him and my mom navigate our world. It was very big, especially as he's older. So understanding not only care, but also communicating with not this but I don't anyone involved. It feels very nice. So I want to be small and be done of what he do or under the of the version is very fun. But I think I'm very curious. I'm very interested in this discussion, especially as we often talk about other payers, not necessarily always very basic care. So I think I'll first start with Melissa. And I think my first question focus on how do employers view the evolution of cancer screenings as part of wellness and pregnancy?
Thanks, really, and sorry, swinging my feet, but I'm a little too short. Apologies. In any case, thank you for having me here today, and thank you all for being here. Conversation today. The first one to say after that is I too really appreciate all the work people are doing, whether it's discovery and development of drugs, or it's patient navigation, it's care coordination, whatever it may be, both for cancer and chronic care issues. This is a very important talk for me today personally. It's the first time I'm back at work. My mother died 9 days ago from multiple sclerosis. She was diagnosed when she was my age. She fought for 26 years and died at home. My dad's been her primary caregiver this whole time while he works. He has Parkinson's himself, has a cobbled something together in the whole over the years. And I'll tell you, my perspective as not just working with large employers, which is important, but as a daughter of 2 parents, chronic illnesses that my mother at least fought for many, many years. It's very important work that you all do. There are a lot of questions that we're moving out here in healthcare policy world about how to make patient access to care better, part of which is coverage, whether you get it through your employer or through a retiree plan or through a federal or state payer. But part of it is also access. Can you afford what you're getting? Can you get it at all? Do you get caregivers? So I did want to just state that because I wanted to honor my mother. This is literally the first thing I've done since going back to work. So I appreciate you all very, very much. So thank you. Now,
I'm so sorry for your loss.
Oh,
that is very, very new.
Yeah, no, thank you. Well, thanks for all the work everyone's doing because it's incredibly important to families all around the country. So, okay, so you asked about cheat sheets out. You asked specifically about what employers, how they do evolution of cancer screening. Yeah.
So it's interesting because, employers have always been, and for any of you who don't know who the ERISA is, maybe like a 3-second, 30-second, So, by way of background, we are a national advocacy organization exclusively representing the largest employers in the country in their capacity as sponsors of employee benefit plans, both retirement, healthcare, welfare benefit plans that they receive through them. Always known as like self-funded health plans, right? With member companies that are leaders in every economic sector. ERIC is supposed to be on the employer plan sponsors, federal, state, local, you name it, we're everywhere. And their ability to sponsor benefit plans. We offer, our member companies combined offer tens of millions of employees and their families healthcare coverage located in every city, state, for so knowing that out there, we are what my perspective is on this. So we're talking large self-funded companies. Think of like a Target. They have employees in every state, and they try to offer uniform health benefits to all their employees. That's part of the value of having something of short. Right? So as these employers have this ERISA preemption, the employer will fool for them because they're able to experiment and do things with innovation and benefit design that, let's say, plans who are subject to each and every state regulator may not be able to do. And so for many, many years, large employers like those who are my members have been at the forefront of trying to do screenings. Cancer, iconic, conditions, or trying to, test innovative ways by which they can contract with regular care doctors, like contract arrangements. There's some that have been involved with ACOs. It was telehealth that was first sort of adopted by the large jumbo employers on a national basis. So they really are the trendsetters in this area, but they kind of are because they do have that flexibility from state regulation. And so that's a critical piece of it. And so as we're seeing these, the innovation evolve, in terms of screenings, and not just for cancer, but obviously for cancer. It's something that employers want to be a partner for. We very much want to be at the forefront of keeping our employees and their families healthy and happy and working long term. And so, you're seeing a sort of change in the dynamic over time where, might have originally just gone in and had a screening for one of the cancer back. Now we're getting into things that are like lung cancer and colon cancer that are blood tested, easy. Everybody's seen this commercial, that kind of thing. It's important because what it's doing is it's meeting the patient where they are, which from my member's perspective is the worker's family member. And it encourages them to take these important tests and do early screening in a way where they're comfortable, where they don't have to take off work, in a way where they don't have to take off work to take their family member to get a screening done. So, I hope you all please consider us partners in that endeavor because there's a lot of exciting things that are being done in that area. And I think we're going to see more and more coming. We're really excited about the one big better bill or one better big bill. I don't know what they call it anymore. I don't know what the Senate will call it, but I will say that, we're excited that included in that bill are a number of improvements to health savings accounts that hadn't been modernized in over 20 years. And there are so many patients now in high deductible health plans that really rely on those tax exempt dollars to plan for their out-of-pocket needs and their payments needs. One of which is being able to use HSA dollars, pre-deductible for high deductible health plans for chronic conditions, chronic care management, screenings, et cetera. Another one that I know we worked on at ERIC, we're really excited that was folded into those HSA forms, included more flexibilities around on-site, work-site health clinics. Can they administer some of these important screening tests? I would say yes. They're trying now. If we were given some more flexibilities, I think it's even more employers doing this on site for their. I don't want to take up too much time, so I'll stop talking.
I'm sure we got a question. I have questions about HSAs too. So I can bring an important sector of our commercial landscape. Millicent, thank you. We do. What are the question I have for you? Why are employers uniquely positioned to support employees living with obesity?
Thank you so much, and thank you for inviting me to this meeting today. So, employers are important because 60% of all employers provide healthcare to people 65 years and under. So imagine just about everybody here in this room is having their healthcare provided to them by their employers. What's important to us at the Alliance for Women's Health and Prevention, which I've been there for 2 years, it's an organization that's only been started since 2022. We provide, our mission is to provide policy, advanced policy for women and girls for preventive healthcare services. And so working with the employers is important to us. Primarily, one of the major reasons is because of obesity. When there are people living looking overweight and obese. And what that means is that for our healthcare system, is that $1.72 trillion, $1.72 trillion costs go to diseases relating to obesity. So those of us who are living with cancers, breast cancer, colorectal cancer, ovarian cancer, cervical cancer. There are at least 13 cancers that are related to breast cancer that are related to living with obesity. Those are major issues for us in the women's health and in the obesity community. People with obesity, living with obesity, are costing their employers $101 billion annually. So that means everybody in this room, your mama, your auntie, your children, all of us could get better health care if we could turn the tide with living with obesity. Women in particular have a major issue in terms of living with obesity. So they're often stigmatized by their colleagues and family members. They're less likely to be promoted, even though they may have the same experience or better or higher education. And they earn 9% less than their coworkers. Now, we already know women earn less than men. Sorry, men, just got to put that out there. But if you are a woman living with obesity, you're earning as much as 9% less. And so when we take a look at that from a policy point of view, or we take a look at it from an employer's point of view, it behooves the employer to consider covering comprehensive obesity care and treatment. Comprehensive meaning that they're taking care of the obesity management medications. They're taking care of the surgery, bariatric surgery, the mental health issues that go along with living with obesity, as well as nutrition therapy. So we need to make sure that employers are taking care of these issues, making sure they're providing these benefits for their employees. Because listen, when it impacts the employee, it impacts their productivity, it impacts their absenteeism and their ability to actually be productive at work. Their presenteeism. They're at work, they ain't doing nothing because they're worried about other issues. And so that's one of the reasons why employers really need to consider providing comprehensive care.
Thank you. Andrea, I know you speak from the young adults perspective, and we'll talk a little bit about how queer plans can help support that, but I was hoping you could first address unique challenges with young adults face when navigating cancer and other conditions during career building years.
So, Amey, since obviously I'm a professional, phrase in your
Hello?
Oh, okay.
There we go. There we go. Sorry. So this is obviously a, professional issue, being at the National Coalition Cancer Collaborative, but also a very personal one. When I was diagnosed, I realized that cancer care isn't just, it doesn't just encompass treatment, but, whole life with it. So you're having to navigate, taking health support, mental health support. Elisa was mentioning, I think somebody else was, financial issues, nutrition, there's fertility issues, which a lot of the times providers aren't addressing with a lot of young cancer patients. So we find experience that I had to bring up myself. And that's oftentimes not covered in a lot of insurance plans. Young cancer patients are at it, right? There isn't a lot of support. May look very different. A lot of patients don't have a robust savings, they don't have a lot of year stability. So these are kind of the unique challenges in that area. And I think this is where employers can really help open these things. And that feeds to also building trust with employees, but also the alliance from the law. And that's available to them. And that's really important to know how to navigate. Because the healthcare system is already very frustrating. I know that it's 8 hours. Well, bigger I have not strats. It's one of the lot.
Jill, it's very nice to have you on the panel. I will talk a little bit in our clinical benefit design. I know that we're very familiar with these terminologies, these terms. Employers have been gravitating towards accumulator, maximizer, and alternative benefit programs. Could you just remind us what those are and what risks do they potentially create for employer sponsors?
Sure. I was a healthcare lawyer for 35 years. I worked with drug manufacturers, I worked with employers, I worked with insurance companies, I worked with PBMs. Now retired. I'm a rare disease patient at the one legal practice and did earlier than I might otherwise have. And all of my experience tells me how hard it is to be an employer offering healthcare coverage. And unfortunately, it's growing even harder. Obviously, in that environment, we see a number of very significant developments. We see the premium cost to employees rising, see cost sharing increasing to employees. All of those have very significant effects on the effectiveness of healthcare coverage when offered by employers. And I'm a critic of all that, but it comes that criticism from a place of sympathy to the employer. And certainly there have been some very interesting and productive attempts at innovation by employers and those working with employers. I've been advocating for 20 years as a healthcare policy and legal advisor that one way of approaching rare diseases is through a subscription model where payment would follow the patient over years and decades as the patient moves from one source of insurance to another, so that the cost of rare disease treatments is appropriately spread over all of those, as payers enjoy the benefit of that payment. So that's great. Some of the forms of innovation, not so great. And I would put accumulators and maximizers and alternative funding capabilities. What do they do? Well, simplified, what all of those do, usually at the suggestion of some PBM or benefits consultant or vendor of these programs, is to, and this is harsh, but I'm going to be harsh, mislead the patient into the suggestion that a service that is actually covered to them is not actually covered, and that as a consequence, they're going to bear more of that cost or have to alternatively access that service. And this presents the risk of sowing mistrust between employers and employees, having unfortunately very detrimental effects on patients themselves from both the financial and a healthcare perspective. I'm sympathetic as to why employers gravitate to these programs, but they are not good programs. And in fact, they expose employers to risk because, in at least my experience, I am concerned that the communications with patients that foster the introduction of these programs are at best incomplete. There is a risk that employees and others will contemplate litigation to try and address some of these programs. And as a volunteer now, environment for multiple patient advocacy groups, it can tell you that a number of patient advocacy groups are looking for opportunities to bring litigation because they perceive this as such a threat to patients, chronic disease space, rare disease space, cancer space. And I hope that we can avoid that sort of resolution by understanding what the problems are associated with these programs.
Thank you very much, and thank you for that background. And I know that we'll be addressing this in more detail in the third panel as well. So I just want to note that, but that was very helpful in your particular perspective also. Melissa, are there particular innovations on the horizon that employers are talking about as part of a possible benefit design?
So yeah, thanks again. So as I mentioned, I think these blood-based communities that can be done it can be good to schedule an employer and employee actually a tremendous value over screenings that require turn off, etc. There's a whole lot of literature out there that talks about why people go to get screened or they told, and part of it is the perception that they had to take a ton off of work and it'd be too much trouble, and it's one of them. I think the more value folks can see in some of these innovative screening models, the better. Because again, we all know that early screening is critical to getting people into the right level of care and working in happily healthy-ish, right? Until the disease, hopefully for the progression of the disease. So again, I think for me, that's the particular innovative area. But I'll see something too that and I appreciate what you're saying. And there are a lot of I oftentimes think about this, and I think employers do too. When you look at the end of the day, you have fiduciary duty to the beneficiaries of the health plan that you're sponsoring on their behalf. And so you're trying to make sure that they're getting the best access to the best drug at the best price or the best treatment, because that's your fiduciary duty. And that's going to look a little different depending on the employer and who their employees are on a regional basis and everything else. But I think that when I think about innovation and value design and benefit design, that's the end goal. I don't know that there's a perfect magical solution to your point, Lynn. Coping people, I don't know. It sounds like you don't mean this, but for some employer, maybe that's important to help, offset some of the premium increases so that they don't have to narrow their formulary. I don't know. But I will say that giving employers every tool possible to work with their beneficiaries and determine what their beneficiaries need is really important. And so, I look at things like the GLP-1s, and there's going to be more talk about this later. That's great. That's innovation. I mean, don't say it's not. Okay. I mean, I think it's amazing. I have some employer members that provided full coverage, no questions asked. I have others where it's for a limited indication, and I have others that don't cover it at all. And I think that's probably appropriate where we are in the game right now. Until those drugs come down in price, I think employers need to make the decision along with their workforce about where they were going to prioritize, some of the access to some of these expensive drugs. Now, in the interim, there are a whole host of things that could be done outside of, sort of these draconian measures, essentially pays and that's or capping drug prices. Why aren't we talking more about PBMs and how they are, putting in place practices that sort of misdirect workers who would never know into a higher priced drug and away from a cheaper generic or biosimilar drug or alternate drug therapy? I mean, that doesn't, that's not innovation. That's just correcting a bad practice, right? So there's a lot of things that employers are 100% fighting for their workers for, because it's in their interest, because they have fiduciary duty to keep those costs down and keep access up. But it's also just, it's the right thing to do, right? I mean, you don't have to reinvent the wheel. You just have to look around and say, why aren't my workers getting access to this biosimilar? It's $50. You're paying $5,000. What's the problem here? Something's not adding up. So, I think, again, that's not technically an innovation, but I would say that employers are very, very sensitive to in the world of drug treatments and access to drug treatments for their workers. I said the other thing that's on the horizon, and it's not really on the horizon. I know a lot of you, I see some familiar faces in the room, but and it was part of the ACA at one point that dropped out the Class Act. But I do think we are at a moment in time, and I think when I mentioned my mother and her journey, where people talk about the sandwich generation and all that, caregiving is growing more and more and more as an important component of total patient care. And so we have to find a way, and I think employers, hopefully, I think a lot of my members are starting to think through this and may offer caregiving supports, but there's more to do. And there could be more that should be uniformly done as sort of the basic, baseline of what does it mean to keep working, but also take care of your loved ones? What does it mean to keep working if you are diagnosed with cancer and you don't know where to go and you don't know, what your full benefits are for mental health, for paid leave, for all of these things? And so I think we're at that moment in time where caregiving has to become a bit of a focus in all of the conversations, not just the high costs of care, but how do we get people the total care they need, so you're not wasting resources and time and energy calling around and around and around and around, just trying to get a bed that your mom had already laid in for 10 months. I rotated her and prevented wound therapy. It just makes more sense. And it seems like it would lead to more savings down the road if we looked at total patient care that way. I'm gonna stop talking because again, I could talk forever. All these things you can talk very casually, but I'll let somebody else have a chance.
Thank you. And I know that for many of us, of course, caregiving is one of our top advocacy priorities in improving that ecosystem, which is really in crisis. Millicent, Melissa was talking a little bit about the GLP-1s, and I was wondering, what do employers stand to gain by offering coverage for comprehensive obesity care for their employees?
Thank you for bringing that up. GLP-1s. So employers will benefit by seeing better employee retention. You mentioned that, and satisfaction. So employers that are best able to attract the best talent, they are best able to keep their employees over time. They keep talking about younger people wanting to move every couple of years. They're able to keep them because the benefit structure is a bit more flexible. 80% of Americans believe that insurance should cover obesity management medications. 30% of Americans would change jobs to gain coverage. 30% would change jobs. They would leave their current employer, if their employer would provide comprehensive obesity care, that's pretty amazing. The coverage for that employers provide would help to, for obesity medications particularly, would help to stem off some of those cancers that we were talking about earlier. When you were mentioning about fertility issues, ovarian cancer, colorectal cancer, breast cancer, endometriosis, all of those have a direct relationship to obesity care. So if we can bring down obesity, people living with obesity, then we can help bring down the costs of those other associated diseases. There are 200 diseases, 200 at a minimum, that are associated with people living with obesity. So if we can bring down obesity and people living with being overweight, then those costs that continue to climb because people are living with diabetes, they're living with cardiovascular disease, they're living with heart failure. If we can bring down obesity, then hopefully we can bring down those costs. And those employees that we love dearly and work well with, who we want to stay with us on those jobs, employers can bring in hopefully more revenue to the company. And hopefully all of us can have a better way of life, be healthier workforce, healthier communities. So it's not just the employer, it's also our family members. So when I talk about our mamas and our aunties and our children, I know those of us who understand children, those obesity has an impact on our entire community. The way that we live, the way that we play, the way that we worship, the way that we go to work, all of that has a direct impact. Obesity has a direct impact. And so when we're looking at obesity as a chronic disease, which it is, it's only fair that we treat obesity like any other chronic disease, just like all the cancers, like diabetes, like cardiovascular disease. Now, with the Alliance for Women's Health and Prevention, we decided to do something a little bit different. We gathered a stakeholder group of 60,000 women from around the country in 1 year. No, your eyes got big. And what we decided to do in pulling these women together was to activate them around obesity. First of all, they had a pledge that they would pledge to do something about obesity. And that something that we asked them to do was to go to their policymakers, to go to their employers, and ask them to make some changes relating to obesity care and treatment. And since I saw the sign that says we only have 2 minutes left, I'm going to stop there. Just been part of that 60,000.
Thank you. Thank you for noting that we have 10 minutes left. Andrea, what does high quality survivorship care look like? And how can employers better support it?
So I want to note that there are over 18 million cancer survivors in the U.S. and that number will only continue to grow. As we know, rates are on the rise for people under 50 and certain cancers. And we've been talking about how to save costs. I'm really glad that we talked about that. And employee retention and these things. Survivorship care, it's survivorship care means juggling different specialists. And it's not just treatment, it's managing late effects. It's juggling different specialists. It's understanding flexible accommodations and what benefits are available to you. And all of that is a lot of time and money and stress. And care coordination plays into that. And if employers can, maybe contract vendors to help with peer support or care coordination, or even telehealth, or coverage for survivorship care. Over in our state of survivorship survey, over half of cancer survivors were not receiving survivorship care, either because they didn't receive a plan or they didn't know where to get it. And so that's just a huge gap that isn't being built right now. And that ends up costing money because there's a fear of recurrence. There's, again, comorbidities that come into play. And as I mentioned, folks are being diagnosed younger. There's other chronic conditions as well, not just cancer. So employees are, that's something that employers are having to deal with, right? We want this is a workforce issue. We want a workforce that is resilient, that is productive. And, when I think about saving costs, I'm thinking we as a patient advocacy organization are thinking about this bill that's being considered in the Senate. While there are some small provisions that may benefit small populations, I'm also very concerned about millions of people that may lose access to health insurance coverage. And that does not reduce costs, that drives up costs. So, these are all things to think about.
Thank you. And Bill, I know you have experience and knowledge on the patient assistance programs and sort of a decrease in those kinds of availability. And you've talked in your publications and presentations about the 340B drug discount program. Is that program good or bad for oncology care and patients in the U.S.?
Well, I'd say it's a little bit of both. Many things in life are complicated. This is one of them. So certainly there are lots of 340B providers that are at the cutting edge of providing terrific cancer care, from academic medical centers to federally qualified health clinics that play an important role in taking cancer care, and the first to congratulate them for what they do and their contributions in a particularly important area. Unfortunately, there's also a lot of evidence out there that 340B covered entities in general, particularly among 340B hospitals that enjoy about 80% and billions of dollars of benefits under that program, charge much higher rates for cancer care, including cancer drugs, than virtually any other class of provider. And in the New York Times and in a series of scholarly studies, that problem has been unfortunately laid bare. And that is a source of real concern. It goes back to the employer side, because one of the groups that goes to employers often through telemedicine concepts is 340B entities who say, hey, this can be a win-win. You allow us to connect with your employees through a telemedicine hookup. We will provide access to 340B drugs at 340B prices, and this can be a win-win. Share the savings, quote unquote. Well, I would say to employers, as I would say in the context of rebate guarantees from PBMs, make sure you scratch the surface of what sounds like a great offer in the first instance, because it may be that you are sharing the savings off of a much higher priced service in the first instance, such that there are no savings. You're actually just paying more. So I think that it's a little bit of a 340B program has many things to be said positively for it. And unfortunately, in hands of some, It is a means by which costs are increased, and the effect of those costs don't even go to the benefit of the 340B covered entities. There are PBMs, there are third-party administrators, there are contract pharmacies, large national for-profit entities that are securing billions and billions of dollars out of this program.
Thank you, and I want to thank each of you. Did you want to?
Yeah, I'm gonna add something to that because I think it's an important point. So, I definitely appreciate it's. I'll say we did a study recently that was put out. ERIC.org is our website. If you go to our website, we had an economic study of SOAR's analysis. We worked with an economist, and we determined, based on all of the different economic literature out there, sorts of habit, that the idea that that hospitals are charging, and I'm not talking 340B necessarily, just saying generally, hospitals and providers are charging employers more than Medicare or Medicaid because they're cost shifting their, the downfall in payment reimbursement from those federal state payers onto employers, and that's simply not true. They're just doing it because they can. And the reason they can is because there's so much market consolidation that's happening. It's not that that's the consideration. It's because they say, hey, we're the hospital system in town. You need this in your network. You're going to pay us 5,000% of Medicare. And then when you start bringing in the 340B question, which I think is a very good one, the one we're definitely exploring and one I've heard from them, which is, because 340B money doesn't flow directly to employers, there's still this question overall, though, about the impact of propping up a system that's artificially inflated in terms of costs and reimbursements based on this 340B driver, based on 340B driving more consolidation in the market. So I think we've just, to your point, we just scratched the surface. Like you scratched the rebate. Yeah, employers scratched that rebate a few years ago. They have not stopped scratching. So I appreciate bringing that to the attention today because, again, I think that there are a significant number of market consolidation problems that are happening in the provider market that are leading to inflated prices that trickle down to patients.
Well, if I may, I'll just, since we didn't agree on accumulators, I'm happy to hear that we agree on this. And one of the points that I would observe to employers is that the more that they work with 340B entities that are unfortunately in some cases too profit and not patient enough driven, and drive utilization to those entities, they are driving the very consolidation that you were talking about, which then allows those 340B entities, as they grow bigger and bigger, acquiring more and more physician practices, to then dominate markets and to raise the charges to your employers.
I think we could spend the whole day talking about this topic. Millicent, did I just cut you off?
No.
Okay. Do we have time for one question?
Yes.
Yes, we have time for one question. Thank you to each of our panelists. Thanks on the attentives.
I just wonder if anyone on the panel could comment on some of the recent data we see is increasing incidence in young adults under age 50, and if there's employer focus on that, where it might be at.
Sorry, more specifically, like a
Young adult cancer increase.
yeah. So I would just like to see more initiatives, honestly. I think we've seen a lot of research, but I honestly haven't seen a lot of specific initiatives. I think we're still seeing a lot of, and I think it's great. I think it's great that we're talking about it. But I have yet to see like more initiatives. And I think that's what we would like to see. I know that I was saying this 3 years ago, and I still heard, "Oh my goodness, you're so young," and my treatment was delayed. And I still hear that with people that are being diagnosed in their 20s. They're still hearing it. And I spoke to a young survivor 20 years ago, and she said, "Wow, they're still saying that." And so maybe let's stop saying that and let's start doing something about it.
I would say from a legal perspective, it's been very interesting to see an increase in employee litigation that is related to concerns about discrimination based on their health status. A group, younger employees who, at least traditionally, in a lot of ways, were lower, less likely to participate in employee litigation, definitely changing now. And in part, that's a consequence of a higher rate of certain diseases in the population.
I would also just add that I think employees are still nervous about asking what benefits are available, asking about workplace accommodations. I still have friends who are afraid to ask, are afraid to disclose, are afraid to ask, they're afraid to be taken off projects. They've been discriminated in the workplace. I'm very lucky that I work for cancer nonprofit, but it's 2025. So
Thank you. Any other, I think there was one other question back.
Sorry, I won't take long. Kim Zubarak with Cancer Care. Bill, I think you were at Bio International a couple years ago, and myself, Cola Kulianis, and some others had a panel on AFP. So you were all excited about it, not encouraging it, but very excited about getting the word out. So thank you on that. And Melissa, I would love the opportunity, post this summit to speak more. I know we've done a little bit. Cancer Care has done a little bit with Eric. Just this statement, and I understand what you meant by it, but that employers need all tools available. I'd just like to work together with employers to make sure that there's some guardrails where when access, for patients with serious conditions is really cut off or delayed so much that it's really not having access, that we can work together. Speaking specifically on the alternative funding programs, I think in the long run, it will hurt employers because your employees are paying really good money for their plans. And I do expect that it will be there, grateful that it's there when there's an ear infection and amoxicillin is needed. But more importantly, people are paying it so that they can have coverage when something serious comes about. So I'd love to engage more in the future with you.
Yeah, absolutely. And I think when I made that statement, it was more about, look, big national benefit mandates are not going to help solve the problem. If anything, they're going to probably hurt the ability of your employer to work with their workforce and their unique workforce needs. That said, I will tell you that I'm not aware, and speaking to my own membership, that couldn't name one that's using the alternative benefit program design. I think the big guys have figured it out when they see a shell game. But that's not to say that it's still not something that is being, sold to them every day as an ability to, rein in their costs. But generally, I haven't heard of any of our membership that's pursued those avenues. Copay accumulators, that's a little different, but again, I'd love to work with you on guardrails. That's a great idea.
Thank you. Can we just all welcome and thank our panel? Thank you so much.
Our copay accumulator program to evolving health policies will examine the challenges and the opportunities ahead in ensuring treatment remains accessible and affordable. We are joined by a powerhouse panel who brings rich perspectives from oncology, chronic disease advocacy, patient support, and federal policy. Please join me in welcoming our moderator, Rich Brennan, Vice President of Federal Affairs and the ALS Association, along with our panelists, Anna Schwongline-Howard, Principal of Policy Development at the American Cancer Society Cancer Action Network, Charles Husser, Federal Affairs Manager for the Arthritis Foundation, Alicia Johnson, the Patient Financial Coordinator at MedStar Washington Hospital and the Georgetown Cancer Center, and Nalin Mouche, the Chief Policy Officer for the American Society of Oncology. Thank you all.
Yeah, they're sick.
Thank you. And I can make sure my mic is. Good afternoon.
Then that opportunity.
Any in that part of the
Give it a light of. Make this.
Is that like? Red is not working. Okay. Thank you all for first of all, the cancer support community, Sally, especially for putting this on today, because I spend every day in this environment as far as utilization and no matter what word you behind it, it still doesn't make sense to me. So I'm grateful to have a powerhouse panel behind me to help us understand the complexities of this issue, especially understanding why I guess the impact of these types of programs, especially on the patients, out-of-pocket costs for patients, especially those with cancer, ALS, Alzheimer's, others that have really complex diseases, are the most difficult things for them to deal with. I know we talked about a lot of different issues, but we say that just the cost of care it's just very important. So today's panel will explore how these programs affect the availability of drugs and also the policy landscape. So I want to get into this right away. And I'm going to go in certain order for lately, but I would like to hear first of all from Anna. Anna, as far as explaining this to us, how can people determine if their health plan includes a copay accumulator and maximizer program, and what type of effect does that have if it does?
Thankful for those of you who can see on the screen kind of a description of a copay accumulator program. Basically, what a copay accumulator program is if an individual accepts assistance from a pharmaceutical company. You see the TV ads, if you can't afford this drug, call this number. And that assistance from the pharmaceutical company doesn't count towards the patient's out-of-pocket costs. It's basically the plan takes the money and it's like, yeah, well, happy to take that money, but we're not going to count it towards the maximum out-of-pocket cost or the deductibles we're having. So really, then the patient is on the hook for paying what they would be paying out of pocket. They so having the manufacturer assistance. And so a lot of people don't know what copay accumulator programs are. I mean, healthcare is complicated. We have lots of different types of healthcare in this country with lots of different types of programs. They all have their special rules. And most people don't know about copay accumulators. We did a study, we at the American Cancer Society Cancer Action Network had through our Survivor Views program, where we poll cancer patients and survivors and ask them a series of questions. Back in 2023, we polled them and said, have you heard of copay accumulator programs? And about half had never heard of copay accumulator programs. And about half had, and many of them had tried to, many of them were impacted by the copay accumulator programs. So, the first thing is most people don't know if they are in a plan that has a copay accumulator program until they are negatively impacted. It's not like if you look at your card, there's a little box that says this plan is subject to a copay accumulator program. But here, more information. It's somewhere buried in the plan documents. Nobody ever goes and looks in their plan documents unless you're like a health policy wonk, like some of us on the panel, to find out really if they are subject to a copay accumulator program. So my advice to people who may be in a plan that where you're going to be using high cost drugs, you're a cancer patient, using drugs you qualify for and get assistance from a pharmaceutical manufacturer. My advice is to call the plan and to ask them. And your plan, it's going to have people at the call center who are going to say, either I don't know, which case you'll say, tell me and find out, or they'll say yes or no. And regardless of what the answer yes or no is, you should ask them if they say, yes, we have a plan with the copay accumulator program. You should ask them where in the plan document, send me in the plan document information on their program. Make them send you that information so that you know what it is that you have, what the various thresholds are and the extent to which you're subject to a copay. So long-winded way of saying it.
No, I think that it makes sense. And what I want to bring into the conversation is, I mean, we're trying to make sense of it as policy experts that spend our time here in Washington, D.C. understanding post-season insurance. What is it like on the patient side to have to get inside this? Is so, Kalisha, you can speak to that as far as how do you respond to a patient that says, my medications are too expensive and I have to deal with this program that they're not, counting the ability of my insurer, and I was maybe or the pharmaceutical company has a discount on a drug, but still I can't afford these.
So, can you hear me? Not 100%. So, of course, I work with patients all across the board, and whether it's cancer or whether it's any other specialty, sometimes they don't know where to start, right? So, to me, sometimes mostly it starts in the pharmacy. So, when they go into the pharmacy, they go in there to pick up their medication. Sometimes they don't even know what they're picking up. So, if they're in there, the pharmacy tells them, "Oh, your prescription isn't covered," or is this price and whatnot. And so then they sometimes don't know what questions to ask as the recipient. So the patients sometimes need to be educated. Some of the pharmacies need to be educated to educate the patients so that they can figure out what's going on, right? Because sometimes they don't know exactly what the issue is or why the copay is where it is. And so there's various reasons for why the copay is high. Then I would check in with the provider's office, check back in with their doctor's office if they have like a patient navigator or something like that to help explain and navigate the process of how, well, why is this, price this, or help them call the insurance company so they can get clarification. Earlier we spoke about the being able to speak it in layman's terms, being able to have that patient understand what you're actually speaking about. They need that for the insurance company too. They need it for the pricing too. They need it for all of those things, the benefits too. So I would start there. And then once you go through there, especially if you have like a financial navigator, then they can really break that down and do an intake and a patient benefits application. And then they can go on the options, explain all of those things. The insurance company, with the manufacturers, or what other option they could potentially go to. Let me ask you a question.
Yeah, I'm hearing from you. This is a problem.
Yeah.
And so we're the solution mind today. But what if I talk about these things? Figure out if there's any inroads that you can make in current policy environment. So Alan's here. Pasco, who I understand has done some really good thinking on this and has policy positions. Wanted to know more about your policy positions and out-of-pocket costs, how those were developed, and then possibly, when are you planning to either here? How do you suggest that the cancer community come together to achieve these types of recommendations?
Great, thank you for that. So hello everyone. ASCO actually identified copay accumulator programs in particular as a specific problem and issue back in 2018 in an older position statement we did on pharmacy benefit managers. So we've had this on our radar for quite a few years. But specifically last year, our leadership, board of directors, leading volunteers, senior staff identified rising out-of-pocket costs as a significant problem for cancer patients and directed our policy staff to work on evaluating issues, learn more about the history, out-of-pocket costs, current state of affairs, and then derive a policy position from that. ASCO engages in evidence-based advocacy, which means that we always start with doing all of our homework and our research first, and we only develop public policy positions that have a foundation in evidence. And so we looked into a little bit of the history and got a little wonky with out-of-pocket costs. Where did they come from? And they were first introduced in plans back in the 1940s and very quickly took off. This idea that people needed to have skin in the game to have this first dollar coverage. And over time, it's ballooned into a very different animal, as many things that health insurance do. And we know today that cancer patients are significantly more likely to report that they are in financial distress, either mortgage issues, bills that are in collections. We know that deductibles have been rising dramatically. They've gone up, I think, 53% in maybe the last 10 years. We know that there are more and more employees finding themselves or choosing to enroll in high deductible health plans. And we know that there are now more and more of these things, such as copay accumulator adjustment programs. My personal perspective is that I don't know why you could call that a program. Seems like a feature of a health plan. I think something like financial navigation, that's a program. But so based on all that evidence that we collected and discussions we had with our members, like we always do, including not just oncologists or oncology research professionals, but also cancer care professionals from across the spectrum. So ASCO membership doesn't just involve your medical oncologists. We have patient advocates on our committees and our policy development groups, as well as oncology nurses and many other different professionals. So based on all of that work, we developed our public position, which was approved by the board of directors and published online on our website in January, declaring that ASCO believes that out-of-pocket costs, and that includes deductibles, copays, co-insurance for the purposes of our paper, are inappropriate for patients undergoing active cancer treatment. And we have a series of policy recommendations that flow from that, some recommendations for Congress, some recommendations for private payers, some recommendations also for employer-sponsored insurance. So I'm happy to talk about more of those in detail, but that's kind of an overview of how we got to where we were. The leadership was very concerned about this. Our membership was really concerned about it. We looked into the evidence, we developed our positions, and now we've moved into the next stage, which is working with all of our advocacy staff. And I am part of the policy team. I'm not one of our lobbyists who goes to the Hill. Working with them to help figure out how do we get that actually in practice. And it may seem like a fairly lofty goal. We hear about no more copays or out of pockets for active cancer treatment, but then we think back to some of the other things that we've overcome in the healthcare space. I certainly didn't think when I was in graduate school learning about these different things that we were ever going to see something like an out-of-pocket cap in Part D. I certainly didn't think that we were going to get rid of medical underwriting anytime in my lifetime. So big things have happened. So we're not willing to give up that.
Thank you for that. I think that we'll explore the question of how, as far as trying to get federal, changes, because it's going to take some time, I understand. But Charles is here because I understand that, first of all, by the end of this year, close to half the states will have developed passed to copay accumulator legislation. I would say that this happens a lot in Washington, D.C., where we see the states leading in policy before the federal landscape sort of takes over and treats themselves. So how can, as far as the state level policy, be helpful in influencing federal policy and getting us to a solution?
Absolutely. So there's been a lot of great work that's been done on this issue, going all the way back to 2018 and then 2019, when we saw the first 4 bills passed at the state level, and leading all the way up until this year, when we're hoping that close to half of the states will have copay accumulator legislation. And throughout, from 2019 through now, there have been many different, I would say, roadblocks that have come out throughout the federal landscape, going all the way back to 2019 with the notice of benefit and payment parameters, when we thought that there was potentially going to be a fix. And then the federal government went back on that and decided that they weren't going to address that issue. And so we've been working on it both regulatorily, congressionally, judicially. I'll shout out Carl Schmidt in the back with the HIV and Hepatitis Policy Institute, who has done some great work on the judicial side. I won't try to explain that at all. I'll just say talk to Carl if you have any questions about the judicial work that's been done there. But leading into this year, where we have introduced the Help Copays Act, the Help Ensure Lower Patient Copays Act for the third straight Congress, trying to move that forward. We've run into roadblocks with Congress this year. Number one, just because if you're coming in talking about anything but reconciliation or appropriations, it's tough to, kind of get a word in edgewise. But also with many of these other issues, there are a lot of opposition to it. Premiums is the number one that we hear, not only with Help Copays, but with many of the issues that we work on. And there's been some great work done by some of the organizations in this room to show that those state level bills, which, as you were mentioning, Rich, a lot of times are kind of those benchmarks. We look at the states that have passed these bills and use that to get data that we can then go into congressional offices to show that a lot of these arguments that are being made just aren't true. So premiums is the first one. The fact that the data that we've seen from the states that have passed so far, the premiums do not go up. There is a negligible increase in premiums. I don't know if anyone's ever seen the premiums go down. Premiums do go up, but it's not because of the copay accumulators or any of the other utilization management tool pieces of legislation that have passed. But we do use state bills, not only the framework, not only the model legislation, but also it's important to keep that connection between the state and the federal level. A lot of these congressional offices will look to their states and see what the states have done to decide whether or not this is something that they want to look towards. And so getting to about half of the states that will have copay accumulator legislation by the end of this year is important, because then we can go back to those state delegates, state representatives, and whether it's a sign-on letter, a phone call, any way to connect with the federal delegation and say, hey, we've done this at the state level. Here's the data that we have. Here's the information, the anecdotes, the qualitative information, all of that. And I'm sorry, but your reasonings that you aren't supporting this just aren't true. And it takes a long time, whether it's Help Copays Act, whether it's step therapy legislation. A lot of these bills have been introduced, for 3, 4, 5, 6 Congresses. And we all know that the federal government is incrementalist. And so just because it didn't pass last Congress doesn't mean it can't pass this Congress, doesn't mean we can't continue to reach those milestones, co-sponsors, et cetera, to try to continue to move those bills forward.
Ellen, did you have something to try to make sure that? Okay. Just wanted to make sure that
Listening intently.
okay, just nodding and you were okay. So, what I'm thinking here, and it's not on my list, but as far as trying to think of this through the patient lens, talking about as far as how things can happen here in Washington D.C. What are you all doing? And this is sort of open to all panelists as far as making sure that the patient-centered engagement is thought of as we approach these types of solutions, and what does that look like for you all in your organizations?
I'll start. I think, your earlier panel today talking about the importance of patient stories and really just bringing it home. A lot of these issues that we're talking about today are really complex and can kind of get lost when you do, research is very important. ACS CAN is also an evidence-based organization. We want to make sure that the policies that we're advocating for are based in research. But what we have found over the years is the personal stories that people have really bring it home. When you go and talk to a policymaker, whether that's at the federal level or the state level or the local level, having somebody come in and say, this is my story, this is what happened to me, and this could happen to anybody else. And I'm using my story to make sure that we can, better some other future person's life. I mean, that's incredibly powerful, and we're so incredibly thankful for the people who take the time and tell their personal stories.
That's kind of the number one thing that we have going on. We also are supporting not only the legislation that Charles mentioned, we're also supporting state legislation, in the states that have passed bans on copay accumulator programs to make sure that we're doing everything that we can to make sure that we minimize out-of-pocket costs for cancer patients, because we know that, if people can't afford access to their medication, they're going to skip it. Which in the cancer perspective, when cancer therapies are regimented, so clearly, and you don't want the disease to progress, we want to make sure that people can afford their medication. We don't want to see people go into debt or have to switch treatments that may or may not be as effective. So all of this kind of building into the personal stories that we use.
And I'll just echo what Anna said, especially this issue specifically. It's not like this is a prior authorization delay, which is very easy for a patient to understand kind of what they're going through. For us as organizations, there's an increased burden of education when it comes to patients for copay accumulators, just because of how convoluted and complex it is. There was a report that came out last year that said 66% of ACA plans have a copay accumulator, and I'm sure that's even higher today. So it continues to grow, and that patient story is the most important piece of it. Many of us as lobbyists, we play our part and we go in and talk to the congressional offices, but it all starts with that story, connecting with the staffer to make them understand why this is something that affects patients, constituents, and then that data piece is super important to come in as complement, but the patient story always has to remain front and center.
I agree about the patient stories. I also think that there's a lot of things that goes on for folks when they get older, right? When it's the 65 and older crew, when they go into Medicare, when they go into these things, they have, I'm speaking of the patient assistance programs, a little bit with that, right? So the drug companies, when you're a commercial payer, you have these assistance programs for patients and they can help cover that co-pays and those things like that. But what do we do? What's going on with the 65 and older folks, with the new Medicare D program, with all these things? I will say that my organization, each year we get innovative. We try to catch and see what's going on for the next year, right? So we can prep ourselves for the patients and how we can help them with different programs and things like that. The Medicare D thing that hit, that was really hard for a lot of our patients, because a lot of the assistance programs are not really there for them to help them cover that medicine. I want to use my mom for example. She's not cancer patient, but she's diabetes. She has uncontrolled diabetes, so she was on an oral medication first. And so that medication went from her covering it from $10, and when she turned 65, now it's $300, $400 a month, which led to her not being able to afford it. So now she's on insulin. I just wanted to throw this piece out there because the patient-centered portion, what happens to them? What can we do to help them in that aspect? I just wanted to throw that piece out there. But yeah, keep, again, my program where I work, I continue to each year, when we look at the legislation, everything that's coming out, and see how ways we can catch the patients and how we can prep, how we can give them financial guidance, beforehand. So I just might be a little off, but I just had to throw that out there. Sorry.
Yeah, the only thing I can add to the conversation is that, from ASCO's perspective, it's been my practice since I've been there, and that's going to be 8 years this fall, to every time ASCO publishes a policy statement, which is a larger document of enduring principles that we publish in one of our journals, we involve a patient advocate on that writing group so that we make sure that we have that experience reflected in what we're writing, and it's not just what we're coming from, research handbooks and our other colleagues and other think tanks, so that we go outside of that. I'm already rooting. Yeah. Hopefully more folks like her. But I do think, some of the things that you were just saying, Felicia, speak to my mind, what are often the unintended consequences when a lot of these lofty policy ideas actually hit the ground with patients, with people's bank accounts. And those are important things for people to know about. And we might not always be able to glean that until it's too late, or until things are so far down the road that we have to come up with yet another lofty policy solution to fix it.
I wanted to extend this even further. And I know that Anna, Charles, Ellen probably easily knock this one out of the park, but as far as we're always trying to look for model programs as and learnings as we go. And I know this has been around for some time, and so there must have been some understanding of like how to approach this. But then there's also probably a lot of variability in states because states approach things differently. So what are the best practices as far as people that are wrapping their heads around that might conceivably be in that fight, federal product, like allow enough flexibility for, depending on a region or a state to be able to make sure this makes sense to everybody.
Yeah, I think one of the best practices is that we've used in our advocacy is, again, going back to the patient perspective. We use the patient perspective not only when we're developing collateral materials and meeting with lawmakers, but we also use the patient perspective when we talk to the media to get the word out there and to make sure that the public is aware of what's going on. I don't know if you know this, but the healthcare system's kind of complex. Just, news at 11. But, most people, when you talk to them and, you'll say what type of insurance you have, they name the carrier. They don't think about insurance in terms of, I have an employer-sponsored health plan that is self-funded versus fully funded versus, whatever. That they think of it in terms of the carrier. And our job is not to make things more difficult for them. Our job, and I think everybody on this panel shares this, is to make sure that we can see into the future and try to eliminate as many barriers as possible kind of going forward, which is why we've been working so hard to enact the state laws, to prohibit the use of the copay programs. Because what we're trying to do is just eliminate as many barriers as possible. They keep popping up, but we're fighting every day.
Yeah, and I'll just first of all underscore what Anna just said. I think all of us would love to just have one bill that could be signed and it affected all health plans and they were all done and don't have to worry about it anymore. But that's not the case. You have the state plans that only focus on the state bills that only focus on the state plans, the health copays, which is ACA plans. There's still Medicare, there's still ERISA, there's still Medicaid. And the fact that not all rules apply the same to each plan makes it very difficult. And also in the patient story gathering perspective, a lot of these bills, we have to make sure it's a story from a specific plan so that it matches up to the bill that we're talking about. And then also Anna mentioned, looking forward, when these bills first popped up in the States in 2019, it was solely copay accumulators. Now we're seeing bills evolve to include maximizers as well. We've heard talk about AFPs and how do we address those as well. It's all about, we don't have a crystal ball. We can't know exactly what's going to come up next, but try to look forward and make those bills as all encompassing as possible so that it's not possible to find that next way to harm patients and ensure that patients in the long run are being helped by these bills so that we don't have to go back and then amend the bill or pass a new bill because in a lot of these legislatures, especially Congress, it's really difficult to go back in and do something that they've already done because they have so many things on their plate that they're trying to pass. And so passing a bill and then going back 2 years later and saying, well, actually, we'll do this as well, makes it really difficult.
And then lastly, because I want to make sure that we have enough time for questions, does anybody else want to answer? Okay. Is just thinking about the future of treatment affordability. Want to give everybody a chance to sort of put their 2 cents in where they think things will go moving forward. Obviously, this is something that is still an issue that needs to be addressed. But I would like to open this up to sort of utilization management in general. But if you want to focus on the accumulators, that's fine. But what do you see? The next big thing to come.
I think we've seen over time that we've been asking a lot of patients. We have been putting a lot of stress on patients, which is unfathomable if you think about it. To have somebody in active cancer treatment who also has to battle their insurance company to make sure that they get coverage, who is then subject to high out-of-pocket costs, or
And they're responsible for
right.
going to Congress and going to
Exactly, and everything else. It becomes a like, full-time, if not part-time job. That is just simply not sustainable for patients to add that stress onto them. What we need to do is we need to enact policies like this. We need to enact policies like common sense step therapy. Make sure that we limit prior authorizations, and kind of avoid and do as much as we can to reduce the red tape and really look at the healthcare system through the eyes of the patient. I think that is what we are trying to do every day. We put ourselves in, we represent cancer patients and we look at the healthcare system through the eyes of the cancer patient, and we're trying to minimize, the out-of-pocket costs and the bureaucracy that exists. So I don't have a single magic bullet to make that happen. Other panelists.
Sometimes it's better you have a lot of thoughts.
I don't know how to add on to that because Anna did a great job underscoring a lot of the utilization management pieces of this. But I do think looking downstream, there are other issues on the horizon. The AI, how is that affecting utilization management? Some of these other, maybe not directly impacting utilization management, but pieces that definitely need to be focused on because they add to delays, whether it's, arthritis, which is a degenerative disease, cancer, where delays sometimes, meet life or death. A lot of these other issues where those delays are occurring, whether it be prior auth, step therapy, copay accumulator, etc., just trying to ensure that the care and the patient are the number one focus to ensure that they can continue to receive their treatments.
Yeah, I would say that we are very concerned about AI for any number of reasons. But last year, about this time, ASCO published its principles for the responsible use of AI in oncology. And we're in the process of getting ready to follow up with some more specific recommendations that are focused on AI and prior auth, because we've been seeing and reading and hearing a lot about how, on the one hand, providers and offices are starting to utilize AI to kind of automate and speed up their ability to submit appeals and things, and to go after denials and to submit their own documentation. And on the other side, of course, we have payers and other companies who are coming up with their own algorithms. So, it's been described, I think, in a couple of places as almost as, just kind of a AI race to the bottom over prior auth. So we're very concerned about AI and trying to look towards some solutions to help increase transparency.
And Alicia, I wanted you to wrap us up with what can we do for patients? I mean, you've been doing at this for 20 years, hearing these stories. Like, what would be the number one thing that somebody here in Washington, D.C. could address?
Well, I think that first we just need to put a better system in place. And when I say that, we need partnerships. Somebody earlier said something about partnerships and things like that, community partnerships, partnering with the pharmacy, partnering with the whole care team as a whole, partnering with the doctor's office, partnering with the authorization system, partnering with the insurance companies, all of them together, because the system needs to be put into one place in order for the patient to have a full care system across the board. Somebody earlier mentioned a care coordinator. I think what insurance companies need the care coordinators bring those back, to help, streamline care for therapy, and they could, just help out.
Thank you. I want to make sure that if anybody has any questions, if we have questions, you got.
I'm Scott Rugged, Health Policy and Strategy Director with J&J. We've talked a lot about the state initiatives. Any comments on the enforcement of state initiatives?
Yeah, that's a great question. And there's no easy answer. A number of states that have these, these bans on copay accumulator program, they don't necessarily know when a person is, whether or not a person is enrolled in a plan that's subject to state regulation or not subject to state regulation. Somebody may, first of all, I don't know if everybody in the room knows this, but in every state and DC, you have an insurance commissioner who is there to help answer questions you have about all lines of insurance. So if somebody were to call their state insurance commissioner and say, hey, I live in a state that has a ban on copay accumulator programs, but yet it looks like my pharmaceutical assistance isn't counting. The state insurance commissioner, it's not like they necessarily have a list of individual plans that may be subject to state law. They're going to say, well, contact your plan and find out these questions. Again, putting the onus back on the patient. And so, it is problematic. I mean, Charles referenced federal regulations around copay accumulator programs. And again, we have Carl in the room, who his organization was very helpful in litigation in that regard. We need clarity. States need clarity to know, okay, which plans are subject, what does this mean? And we don't have the clarity right now. And that's particularly problematic when we have laws in the books that are there to help patients, and we just don't have the enforcement that we need.
This might be the most random question that you received today, but on TikTok, Jerry, pulling you, I apologize. On TikTok, there's this trend where people are currently comparing their medical bills from when they have insurance to what it would be if someone was uninsured, and it is spreading great like wildfire. What do you think we have to have insurance? We understand there's rates. There are going to be different rates based on plan agreement. All those things happen. But what do you think is the answer to educating the community on why there are variances, but also holding hospital systems and medical systems accountable when the variance is so great? For example, I saw one a few weeks ago that it was almost a $25,000 difference in the administration of their medication, not the cost of the drug. $25,000 just in the administration. So how do we help the community understand that some of this is necessary? I use that very hesitantly, but it's part of the system. And then also hold systems accountable for how drastic the variances are.
Yeah, I think I don't have TikTok. I see TikTok videos on like Instagram, like people my age. But I would say know before you go. Like, part of the variance comes from, is the doctor that you're going to, or is the hospital that you're going to in network? If they're in network, where are they in terms of the plan network? Are they a preferred provider? Are they a non-preferred provider? And that's going to differentiate between costs. So if you have the ability to know ahead of time, obviously in an emergency situation, that's not applicable. But, people should review your plan network and call your provider ahead of time and say, okay, give me a ballpark, give me an estimate. What costs would I incur if I went to you versus, if I went to somebody else? Do your homework ahead of time. That's one thing I would say.
And I guess, can I follow up just to that? I guess my question would be is how do we help them prepare for homework? Because
they don't know.
They don't know.
Right. It's another example of we're putting the onus on the patient. Like, we expect you, patient, to do something when you have not been given the tools or understand, why, to go ahead and do this. I think part of it is patient education and letting people know ahead of time, you have rights as a patient. So much in the healthcare system is like done to you as a patient, but it's okay to ask questions. It's okay to, shop around to find out, okay, do I want to go to this provider because it's closer to me? Do I want to go to this provider and that provider? When you get a hospital bill, you can call them up and say, I don't understand this bill. Explain it to me. These are all things that people should be doing. And we need to educate people and we need to empower people. We also need to make it simpler. You know, I mean, think about it in terms of, you know, you have a patient who is living their life, they're going off and doing, you know, things, and then they interact with the healthcare system, which is complex, and they use words like coding, and they, you know, use words like, you know, ERISA and preemption, and nobody knows what these words mean. And you have physician offices or hospitals or, you know, health plans that's all they do on a day-to-day basis. It's really off-putting as a patient because you just don't have the power. And I just think, like everything else, we need to educate patients, and we need to make sure that, you know, they're aware of their rights. There are, you know, a number of resources out there in terms of educating patients. But I think we also just need to, you know, spread the word. And we do that through part of our advocacy, like when we deal with copay accumulators, to kind of educate people about, you know, these copay accumulator programs. This is what they are. These are the problems. And that's why we bring things back to a patient level.
Thanks. You know, I completely agree with you on the need for patient education. I'm wondering if we, as a community, all the groups in this room, because a lot of our groups, the patients that we represent, they have similar diseases, or their family members have the other diseases. Could we join together to do some kind of joint education campaign? Because I think, like, individually, we can't make as much of an impact.
Yeah, and I think, you know, a number of our organizations all do you know, work together. You know, we also have call centers. A lot of our organizations have call centers. I know the American Cancer Society's call center operates on a 24/7 basis. And what we do see when you actually talk to patients is you may have somebody who says, you know, I battled, you know, I had arthritis and these are the problems that I have. And then they talk to somebody who is battling cancer and they say, you know, you should look out for this step therapy, or you should look out, you know, for this. So a lot of it is also just making sure that we not only educate our patients, but we also make sure, you know, give patients an opportunity to talk to each other. But we do have the responsibility to make sure that we remove as many barriers as possible. Yes, patients need to be educated, but like we can't just keep putting more and more stuff on the backs of patients and, you know, expect that system to function.
And I just want to emphasize, you know, what Anna said. So Arthritis Foundation also has a helpline that you can call. And it's amazing to see when patients are informed how it spreads. You know, similar situations to what Anna was talking about. Well, if patients call and said, I've talked to my friend who has X and has said, you know, step therapy is a big issue. What do I need to know going into it in order to try to circumvent it or try to ensure that it doesn't happen to me? But unfortunately, that's not enough. You know, Roxanne, to your point, Anna, to your point, you know, it does fall on us a lot of the times to ensure that our patients are empowered as much as possible, especially on something like copay accumulators, which is such a complex issue. You know, we were joking beforehand, step therapy, we can explain in about a sentence and a half. Copay accumulator, it takes an entire day summit to explain what that is and what's going on there. So, you know, when patients are dealing with not only their day-to-day life, but also their disease management, their patient journey, they don't have time to go and read through all of these, you know, long convoluted explanations, whether it be their explanation of benefits or something that they've Googled and read online. And so I think a big thing that we as organizations can continue to hone in on is how do we take such complex issues and dial it down to something that's really easy to understand and doesn't take a long time to explain.
And I was just going to say, like, that's why we also work together. We don't think of it in terms of, you know, a cancer patient. That's it. You only have cancer. People are people, and they actually have, you know, multiple diseases at the same time.
I'm just like, of course, you know, the community is really big. And so different community support programs are really big. So some of our organizations have community advocates that go out into community to try to help it prevent and do surveys and things like that and get the patient needs and things like that. Some more classes, just, you know, cancer support community has a lot of community programs, but just getting back into all the communities so that the advertisement is there, and then that can help educate the patients better on options that they have to better their health care.
Very well. That's all the time we have, but I wanted to thank everybody and hope that you all walk away with some practical insights and ways to understand how to approach these cautionary complexities, and hopefully also understand how to activate your communities on making a difference. getting some better legislation behind this. So thank you to everybody on the panel.
For our panelists for an outstanding, thoughtful, conversation, illuminated the real complexities with respect to affordability. So what we're going to do to keep us on track, we are going to take a very short break, and in 5 minutes we are going to. We're fortunate to have another powerhouse panel to guide us through this very important conversation. Leading our discussion is Tana Sheehy, Director at Levitt Partners, serving as our moderator. Joining him on the panel are Carl Schmidt, Executive Director of the HIV and Hepatitis Policies. Holly Webster, Senior Health Counsel for the United States Senate Committee on Finance. David Weissman, Director of Congressional Affairs at the National Community Pharmacists Association, and Jess Wysocki, Director of Health Policy at the National Association of Manufacturers. Each of these leaders brings a unique perspective on policy, patient access, and industry dynamics. Please join me in welcoming them to the stage as they help unpack one of the most pressing healthcare issues of our time. Last but not least, that's the last panel over there.
I was like, am I on or the right?
It would be to find out. I don't know, right?
We're here.
Well, thank you so much, cancer support community, for having us, and thank you to my esteemed panelists here. For very, very brief context, just given that I know we're running behind. I know Polly in particular, as a Senate staffer, has places to be and probably a very hard stop. But prior to moving over to Levitt Partners, where I work on behalf of a bunch of healthcare clients, but I'm not speaking on behalf of any client today, nor on behalf of Levitt Partners. I'm here as private citizen Connor. I spent 8 years in the Senate, most recently 4 years in the Senate Finance Committee, where I had the distinct pleasure. This is one of the few times I'll talk about Capitol Hill right now. That is in an unironic. Oh, yeah, this is great if I learned to use technology in my time on the Hill, which I clearly did not. But had the distinct pleasure of working alongside Polly Webster, who was my counterpart over on the Finance Committee, as we worked through, I think, some of the most comprehensive PBM reform efforts that Capitol Hill has seen, which I will give Polly the opportunity to speak to very shortly. But this is a terrific panel, and I think I'll give everyone the opportunity to introduce themselves, provide whatever backgrounds needed as they're entering into their remarks. But just from a framing standpoint, it's worth noting there is a lot going on in healthcare policy in any given day, in any given week. I think particularly this week, it feels like some of us would love a break from contentious headlines and updates. They often come on Friday afternoons and Monday nights. They come in op-eds, they come in expos. It is a wild time. It's contentious. This is a budget reconciliation summer, which can be a very shirts and skins, partisan exercise. But I think part of the beauty of this pharmacy benefit reform conversation is it represents a sweet spot of bipartisan and bicameral interest across folks on Capitol Hill. And I think if you look at the composition of today's panel, it really underscores and illustrates why we have seen so much momentum on pharmacy benefit manager reform, not just in the federal government, where we kept coming up short at the 11th hour, but where you continue to see a ton of momentum and interest in both chambers, but also at the state level. This was a key topic of discussion for the last panel, but just last year alone, there were more than 33 pharmacy benefit manager reform bills enacted across more than 20 states. All 50 states have seen pharmacy benefit manager reform legislation enacted. So the states are not waiting on the federal government, and yet I think there's no question that the federal government has a key role to play in the PBM reform conversation. So given that, despite sitting at the far end of our panel, Leslie was the first on our initial list. I'm going to start with you, Leslie. And let's start with talking about this issue from the perspective of patients. This can become a very wonky conversation very quickly. I think folks can think about the healthcare system as a Norman Rockwell painting where a patient walks into the doctor's office, gets the prescription they need from down the street. I don't think Norman Rockwell ever would have attempted to paint the system the way it is now. It would have been an ugly flowchart, it would have been overcomplicated, and it would not have sold. But the reality is the patient remains at the center of the conversation when it comes to a lot of ongoing reform efforts. So Leslie, you're with the National MS Society. I believe about 1 million patients living with MS across the country. Folks who have seen on paper a ton of medical breakthroughs in recent decades with respect to MS, thanks in part to your organization and its research efforts. And yet, we continue to hear about barriers. And the FTC, in its report earlier this year, I believe, cited some MS modifying therapies as areas where they had seen some of the potentially alleged, I don't want to get in legal trouble for any of my moderator remarks here, but some alleged anti-competitive or problematic PBM practices. So let's start with a very high-level question. What role do PBM practices play in creating barriers to access for patients? And on a related note, there are so many PBM reforms all over the place under that umbrella. What do you see as the highest leverage PBM reforms from a patient perspective?
Thanks, Werner, and I love private citizen car. That's kind of all you know. So, I think from backing up from a 30,000-foot level. So, at the National MS Society, we exist because people live with MS. And our goal, and we want to put ourselves out of business. We want a world free of MS. But until we get there, what we want to see is we want to empower people to live their best lives. What do they need? You know, a lot of people are on disease modifying therapies. Those first came to market for our population in 1993. And you are absolutely correct. We now have more than 20 disease modifying therapies. I think we were the first to say we're very fortunate in that aspect. But what we have seen as more products come to market, the price of those products have kind of done the exact opposite of what you would see in a supply and demand market. The more products come to market, the more expensive they get. The average price of a brand MS disease modifying therapy is upwards of $100,000. I think it's actually now around $120,000. So, I mean, you know, these are not one and done medications. People are on these medications for years, if not decades. So you can kind of see where the problem is already coming into play. I will take your art metaphor, and I will say from the MS perspective, I more view the PBM problem is, you know, I'm dating myself, another geriatric millennial here, but you know, when we were in elementary school, you went into the office, from my perspective, and you saw those paintings where you had to really focus in on one effort and you could only really see the image. I never saw the image, but I sort of see PBM as kind of an allusion to that. It is a part of a bigger access issue with the American healthcare system. What we have seen in the MS space, you know, could really be other patient groups' experiences. I think ours was particularly highlighted because of the expensive nature of some of our medications and the length that people are on them. But, you know, things like, you know, what we would want to see in a perfect world is a shared decision-making process where a physician and a patient enter into a discussion around what the best treatment for that patient looks like, and then access to that medication. What we do now see is step therapy, prior authorizations, and, you know, in my role at the National MS Society, we see both from the patient perspective, but also from the providers are saying, I want to get my patient on this treatment. I think it would be the best for them. I'm spending so much time on the phone with a prior authorization, pushing it through, the denials, step therapy, having my patient be forced to take a medication I know is probably not going to work well for them, and then having that then, set their treatment back. I think MS is, a really hard example because when you're suffering a relapse, that is damage to the brain that we cannot yet repair. So step therapy has dire consequences for those living with MS. So I think in terms of what we've seen, it's the cost of that. It is the cost to the system of kind of perpetually putting people through that. Some of the things that, to your latter question around, things that would have more direct access on patients. I think from my perspective, one of the things that's often not talked about is the incentive that's driving the problem. The way PBMs are set up, it is really, you're incentivized to use that highest cost medication. And I think that's sort of what the FTC report was looking at in the MS example, because it doesn't matter that it is a medication that has been on market for 20 plus years. It's still $100,000. And the newer medications that have slightly, I would consider better efficacy, are also $100,000. So, you're seeing the incentive in the system. For me, delinking, I know there are many other, banning spread pricing, things like that will have a direct impact on patients. But I think to truly get at the bottom of what we need to do, delinking and taking that incentive away is probably an area that is less talked about, because of course you would need the federal government to do that. But it is an area that I would love to have more focus on moving forward.
Thanks so much, Leslie. Let's build on that. Carl, yet another area with both different forms of viral hepatitis and with HIV, where we've just seen miraculous breakthroughs in terms of therapeutic development. When many of us were growing up, folks still talked about HIV as a tragic death sentence. Now, if you're 20 years old, you're diagnosed with HIV, you can expect very reasonably to live 50 or even more years. Tremendous progress, tremendous excitement. Again, whether you're talking about Hep C, HIV, with respect to PBMs, if we're talking about HIV patients living with viral hepatitis, where do PBMs come into play in terms of determinations around access and affordability? And what does the regulatory and legal landscape look like with respect to these issues? Because folks want to believe there are good consumer protections, but you've been working on these issues way before it was cool, and would love to hear your take on that aspect.
Yeah, thanks. And thanks for the cancer group to bring all of us together from different patient disease groups. We all have the same issues, and it's access and affordability of prescription drugs. And a lot of people think it's the insurers who decide what drugs are on a formulary, or how much it's going to cost you, what tier it's on, or if there's prior authorizations, other utilization management. But in reality, it's the PBMs. And basically they've been unregulated, and we have wonderful laws on the books. The Affordable Care Act. There's non-discrimination protections. We have rules implementing those protections. You're not supposed to put drugs to treat a certain class all on the highest tier. You're not supposed to have excessive prior authorizations. You're not supposed to you're supposed to follow treatment guidelines, acceptable national treatment guidelines. But are they being enforced? And the PBMs are hiding behind the insurers, even though they're the ones making these decisions about what drugs get covered and at what tiers and things like that, all based on rebates and how much money they're going to get. But we do have laws in place. Unfortunately, they are not always enforced. And as I said, the PBMs are hiding. The insurer is the one who is the regulated body in our system. They're the ones that are accountable for the Affordable Care Act. They're the ones who are accountable to state laws. And So now with more, you talked about more states getting involved. More states are regulating PBMs. They were left out of this. They were getting, on purpose. So now they hid behind the insurers. And so now that's changing when now state regulators are saying we can regulate them and they could review their decisions. So yes, it's great to have federal. We need it. But we also have to have the state as well that does a lot of the regulation. Now, the big holy grail, I guess what you would say, in PBM reform is if they act as a fiduciary to us, the patients. And right now, it's the insurer that does. And some states, I've seen some bills that put, right now the PBM works for the insurer. They don't work for the patient. But if you put the fiduciary responsibility with the PBMs, that can help as well. But right now, the answer is they've been really coasting and not regulating.
Thanks so much, Carl. Polly, to shift to you, you work for the Senate Finance Committee. Some would say the most important and best committee in the United States Senate. The reality is Senate Finance has jurisdiction over Medicare, Medicaid, and CHIP. They do not have jurisdiction over the commercial health insurance market, but fair to say Medicare and Medicaid policies often serve as sort of a benchmark for all of the other markets. So with that in mind, I am not going to ask you to talk about reconciliation. That is a sensitive shirts and skins exercise and fully recognize that remains fluid. But bigger picture beyond reconciliation, this has been a bipartisan area for your boss, for Ranking Member Wyden, for a little while now. I'd love to hear about what you and your boss are prioritizing with respect to PBM reforms. And I think as a slight add-on, are there additional issues that you all are tracking that maybe weren't on your radar back a few years ago, but that you'd like to look into tackling moving forward on this front?
Yeah, thank you, Connor. And is this working? Okay, there we go. Thanks, Connor, and thank you everybody for having me. Usual disclaimer off the top that my comments are not for attribution and reflect my views instead of the ranking member. But yes, there's sort of a famous story in Democratic Senate circles about how Ted Kennedy worked for so many years to pass the minimum wage. And then he finally got it passed. And while they were at the signing ceremony, a member of the House walked up to him and said, well, what are you going to do now that you finally passed the minimum wage? And Ted Kennedy turned around and said, I'm going to introduce another bill to raise the minimum wage. And I feel like that is how my boss is about middlemen. So, of course, the top priority is to pass the legislation that my boss worked so hard with Senator Crapo, as well as literally like every member of the Finance Committee last Congress, made very meaningful contributions to that legislation. And I cannot overstate how extreme the disappointment was to see, defeat grabbed from the jaws of victory in December on that front. But we'll continue to push for it. But there was a lot because we were under very stringent timelines last Congress to get to markup and, to try several different times to get to the floor unsuccessfully. There was a lot that we had to leave on the cutting room floor. So even though I do feel like the Modernizing and Ensuring PBM Accountability Act took really significant initial steps to start cleaning up the mess, I do think that there is quite a bit more to do on cost. Things that we wanted to do, like bring co-insurance and Part D closer to net price. There is a lot of concern expressed throughout the hearing and the markup process about gross inflation of generic prices in Part D, including specialty generics to treat cancer and other serious conditions. That's something that I think my boss would still like to take another look at. And even beyond that, things we didn't talk about, I mean, more than half of seniors in traditional Medicare don't have Medigap and are still exposed to really high costs and other part of the medical benefit. And some of that is being pulled in to the PBM rubric as well. And so I think there may be more to explore there that's sort of outside the original realm of what we were viewing as relevant to this process. But I think that there's just a lot more to do in order to make sure we're directly channeling these benefits towards patients. And even in the context of the Inflation Reduction Act, I mean, obviously there's a lot of talk about that right now with negotiation, taking effect next year. I think even there, some of the problems that we've been talking about in the context of our PBM efforts are going to become more apparent when patients, can't access a drug with a lower MFP because there's a brand therapeutic alternative that's highly rebated that a plan or a PBM might decide to prefer over that product. And I think that a lot remains to be seen about how CMS is going to plan to handle those types of issues moving forward. So I think, for our bosses on the Democratic side who really care about the IRA being a success, I think that the PBM issues might start bleeding into that world as well and kind of, bringing some of these topics back into the forefront of the conversation. But I will say, sort of at a macro level, in terms of returning to this debate, I do think that a lot of what's going on right now is changing the dialogue on health policy in ways that I think if you all are going in and advocating for these policy solutions with Democratic members, their minds right now are on millions of people potentially losing coverage. And obviously where a patient loses coverage, the types of things that we're talking about today in terms of utilization management, prior auth, and cost sharing, we can't even help those patients anymore with these policy solutions. Or if the science that's needed to develop or approve a drug, or the science that's needed to ensure the drug is covered gets undermined, then that drug is then inaccessible to patients. And so I think that when you're going and advocating to Democrats, they will want to know where your organizations are too on some of those bigger macro issues, while you're advocating to ensure that patient access to therapeutics is strengthened and maintained.
Thanks so much, Polly. David, your organization has been, and I'm sure will continue to be, a huge partner for a lot of the ongoing congressional efforts with respect to PBM reform for a lot of patients in rural areas and in other communities. Your pharmacy members are the frontline healthcare access points. Could you talk to us a little bit about where pharmacies fit into this broader PBM reform discussion and what types of policy solutions are key priorities in terms of preserving those community pharmacy access points?
Yeah, thanks, Connor. I mean, you kind of said it yourself about how community pharmacies are the first line of healthcare defense.
I worked for a rural member for long enough that I had to.
Gotta put that in. Yeah, first line of healthcare defense. A lot of patients will go to their pharmacy, especially in rural areas, before going to a doctor, or if they have some more minor health issue. And then even if they have a prescription from a doctor, they still got to go get that prescription. And if you're in a rural area or even an urban pharmacy desert, we're seeing more and more of those these days. To make a patient's travel a long way to a PBM preferred affiliate pharmacy, or their local one goes out of business, or maybe, their local pharmacy goes out of business, they have to go to a big chain and they're not going to get that level of service. So maybe if the PBM is increasing their price that they have to pay for a drug, your local pharmacy is going to be able to help you and work with you a lot better than maybe a more personal chain. So as far as kind of things that could concretely help, we talked a lot about, I think, how there's a lot to be done even after we get what we've been working on done. A lot that was left on the cutting room floor, as you said, Polly, in December. So I think even if we got everything done from the December continuing resolution across the finish line, I think there's still other things that sort of are pie in the sky ideas right now, or we're not even thinking about doing, and stuff that could kind of help not just community pharmacies, but also patients and healthcare providers and other kind of parts of the healthcare system.
Thank you so much, David. Moving to Jess. When you talk about manufacturing, there are any number of different topics right now that I'm sure many of your members are thinking about but I want to zero in on asking you a couple questions about manufacturers as employers. 90% of your members are small businesses. Many of them cite rising healthcare costs as a key area of concern. So for your members as employers, what role do PBMs currently play in terms of that healthcare cost conversation, and recognizing how engaged you all have been in these reform conversations? What types of areas are your members prioritizing with respect to PBM reform?
Sure. Thanks for that question. I'm Jess. I'm at the National Association of Manufacturers. As Connor said, we have over 14,000 members, small, medium, large manufacturers, and 93% of manufacturing employees are eligible for employer-sponsored insurance, which is a huge percentage, unfortunately, and a rare percentage. But PBMs, without a doubt, are rapidly increasing healthcare costs. We do a quarterly outlook survey of our members, and for the past 2 years, past 8 quarters, rising healthcare costs has been the top, the second, or the third top concern and challenge for manufacturers. So it is top of mind. And, when we look at PBMs, we see the perverse incentives they have, right? They raise costs and they charge employers more because that's what their compensation is linked to. And then we get to steering where they're pushing patients, employees, to take a more expensive drug because they get a bigger kickback from it. And then we go to rebates and they pocket the rebates, and then they've created GPOs where they can extract even more money from the system. And what you have at the end of the day is employers spending a lot of money to ensure that their employees have health insurance. And our members are committed to providing health insurance. Number one, it's the right thing to do. They believe that's part of being a competitive employer, is ensuring that your employees are well taken care of. It's also a workforce issue. We do not have enough manufacturing workers in this country. And it's going to get worse. And not only do employers have to be competitive in their compensation packages, which includes really good health insurance, we need a healthy workforce. And if insurance is so expensive for the employer, that's one thing. But when it's so expensive for the employee as well, that can look like them getting sick and not going to the doctor. Instead, they're calling out of work. They're going to the doctor, but the PBM says you have to take this version of the prescription your doctor provided or prescribed, and it's too expensive. So they just take more time off and get sick or stay sick. And we can't afford to not have a healthy workforce, especially given how important manufacturing is to our economy. But again, I do want to extremely emphasize that our members do believe that it is the right thing to do. These are secondary effects. The top 3 PBM reforms were committed to helping Congress get across the finish line. Transparency, because employers don't even have the information they need to ask the questions that need to be asked to ensure they're getting the best deal they can for their employees. They don't have a view into the data to compare what different PBMs are offering, even though there's only 3 that make up 80% of the market, which are owned by insurance companies and so on and so forth. So there's really only so much competition there. But transparency into just what's going on. Delinking is huge. It's been mentioned several times already, so I'll leave it at that. And then full rebate pass through to employers. Rebate pass through will drive down costs. Employers will get that back, and that can go back into the health insurance or healthcare ecosystem for their employees. And the NAM, we know that reforms are likely to happen first in the federal markets, and we
we want to see that happen. Commercial markets, it's very important that the commercial market isn't left behind when we're looking at reforms. Even if they can't all be done at the same time, employer-sponsored insurance covers a whole lot of people in this country. I believe it's more than all federal insurance programs combined. So we can't forget about those folks when we're looking at what to reform.
Thanks so much, Jess. I believe we have time for a couple questions from the audience. Although again, I don't have a timer or a clock on me, so someone can correct me if I'm wrong. Perfect.
We're gonna watch though.
I'm not even that geriatric.
Hi, thank you guys for this panel. It's been really great so far. My name is Ariane. I'm a postdoc fellow at the National Pharmaceutical Council, and I conduct health policy research and support our communications team. So I think most of us are paying attention to what happens next with Arkansas, specifically with their most recent PBM bill that's passed. And I was wondering, especially with this title, is how do you begin to untangle the PBM payer pharmacy relationship without negatively impacting patient access?
Happy to chime in. I mean, I defer to others in terms of like specific substantive recommendations, but I will say one thing that we talked about a lot in the context of the Finance Committee PBM reforms is that there is a whole higher layer to this conversation of, is Medicare even properly designed to regulate vertically integrated entities? Because there's so much internal transfer pricing gaming that can go on that is just completely outside of the view, let alone the regulatory reach of CMS. And so I do think that that is a conversation that just has to be on the horizon, because it's undoubtedly, driving up costs very substantially, not only for patients, but also for taxpayers. And, a lot of what's happening with United Healthcare and Optum is facilitating that conversation. One of the things that our bosses were really concerned about towards, the later stages of the PBM process were these private label offshoots of PBMs that are now marketing biosimilars at what appear to be, grossly marked up prices. And I mean, that does help with biosimilar access, and it does make a product available at a slightly lower, list price to a patient. But, our belief is that there's still like several hundred, several thousand% markup on the price of that drug that's probably hitting the PBM or PBM affiliate's bottom line. And so I think there are very serious policy questions about how we should look at that behavior in terms of calculating things like a medical loss ratio or calculating things like subsidies in the Part D program, because I don't think that it's fair to ask taxpayers to be subsidizing, profit margins to that extent, especially when it also has such a negative impact on patient cost. So
yeah, I was going to say, if I can just add to, I think from a research perspective as well, and would love to talk to you offline, but I also think it's really helpful to point it out when we are doing research into vertically integrated entities around what are some of the caveats, what are some of the unknowns, calling that out and raising awareness around that. We've heard from the last panel and since most of us are with patient advocacy organizations and touch patients from a number of different avenues, just getting the information out there. I think people, we've heard, as some have said already today, healthcare is complicated, but it's not just complicated, it's so vertically integrated. And I think calling out and raising awareness on where where that is happening and where, it is so complicated. Sometimes what we hear from people is, I had no idea. I had no idea that this owned this entity, which controlled what doctors I got to see, which controlled who. So I think in terms of research and anything that, you or others are putting out there, I think it's also really important to call out where further areas of study are needed, or what are those unknowing variables that are complicating a real answer? Because I think sometimes we're so caught up in the perfect, getting to what Polly said about moving the needle slowly. I think, making some of these assumptions, but acknowledging that there are some assumptions, and that more research and interactions and integrations need to be considered down the line. Because I think, again, we all want perfection, but we know it's going to take a while to get there.
And just to chime in, our members face a lot of economic pressure from PBMs, but if you look at Walgreens and Rite Aid, which are, national reach, a lot of market power, all of their closures that they're facing, it's because they're not vertically integrated. They don't have that big success.
So Leslie makes their point. It's not only the vertical integration, but it's also who they're working with as well, the PBMs. And I know the last panel was copay accumulators and maximizers, but it's because of the vertical integration that they're able to do these accumulators. But with these maximizers, that's where they're making billions of dollars. And so what they're doing is they label drugs non-essential health benefits. And these are the PBMs working with these third-party vendors. And they are really, I don't have to get into all the details, but they are pocketing billions of dollars, and they're splitting it with the PBMs and the third party, and then the plan sponsor as well. And it's a scheme that we have to end.
So I had a comment as well. I think we all agree that we're looking for ways to be more efficient, and certainly trying to get the right treatments to people to try first is a way to be efficient. It's fortuitous that, Polly, you're here. There's a bill that I've been advocating for a few years, Senate Bill 755. It's called the Finn-Sawyer Act. And what that would do is it would mandate Medicaid, Medicare would ship coverage of molecular diagnostic testing at diagnosis for cancer patients, which would lead to them pursuing the correct treatments more quickly and lower costs, and obviously increase chances of survival. I would love to see if we can connect on that and get an audience with some of your finance committee members. And this is a bill that Cancer Support Community posted recently that they are in support of. So if anyone else in this room would like to consider supporting an effort like that and similar efforts, I would love to have that conversation.
I'm just trying to look at something without a lot of calls. Sorry, I'm mad. Well, I mean, when you talk about vertical integration, and you talk about, one of the big challenges too that we have been facing is the extent to which P&T committees, a lot of times they're contracting out a lot of this work to create preferred drug lists, and yet the evidence base for the decisions that are being made, right? I mean, the law says you're supposed to be making these decisions based on good clinical guidelines, et cetera. But the actual evidence base is not transparent, getting to the issue of transparency. That's part of the PBM discussion. I mean, and that's something that I think is, I remember at one point in the last couple of years, CMS would be like, well, point to us where qualities are being used to make these decisions. And I'd be like, we can't. It's not transparent. We know it's happening, but we can't point to it because there's no transparent evidence base for the decisions that are being made in terms of the preferred drug lists or the part of benefit design, et cetera. So I just would point that out as another, I think, place where this transparency thread maybe needs to be explored and researched and understood a little bit more.
Yeah. Can I just say on that, I agree that transparency is a crucial first step. And there's a saying that, like, sunlight's the best disinfectant. Sure, sunlight shows you where it needs to be disinfected. And that's kind of what transparency will do. And that's why transparency alone is not enough. There in some conversations, if we just have transparency that will show all the issues with it, okay, and then we get to see all the issues and don't have any recourse to fix it. So to your point, when I've been trying to find examples, and I previously worked on the Hill and was trying to find examples and to demonstrate why this is needed, it's so hard, and you just kind of have to say, just trust me, just believe me, which is really hard when you work on the hill. So
It's really hard when you work in a policy period.
that's it.
More questions? All right.
Yeah, should we wrap up, or what's the time? It's if we've got, so for the last go round, I would love if we could just go down the line and everyone could say if there's one sort of key takeaway with respect to PBM reform, whether it's one policy you'd like to see enacted, yesterday, or whether it's one key piece of information that you think could be helpful and inform the dialogue. Let's just go right on down the line, and then we can actually wrap up. Apologize for my timekeeping.
I guess we'll start. Well, we need to get it done. Something done. And it's remarkable that it's the unanimous views on this. The business community, the patient community, a lot of others in the healthcare space, agree on this. And it's just remarkable, the opposition to it. And I guess a lot of it's because there's a lot of money involved, and also the lack of transparency. And but I just say, yeah, it's just amazing that we have, we all agree on this, and and we see it in the media and everything, but we still, and even President Trump calls for it as well, but we still can't get it done. So let's get it done.
No, I mean, that's my takeaway and sentiment as well. And like, I know this sounds ridiculous, and this come up on other recent panels on this topic, but the page length factor was a real one. And we dropped many, many pages out of the bill prior to December, and like, there's no more that we can drop. And so I think going to lawmakers and explaining, like, this is such an important step. Oh, we have to do this. Like, it needs to be thoughtful, given, the complexities and sort of creative entrepreneurial behavior of this industry. Like, it has to be done in a way that's relatively prescriptive. But there is huge, broad bipartisan support for getting this done. And our door is, of course, always open for that next set of policies that my boss will inevitably ask me for as soon as this finally passes.
Yeah, kind of speaking to that unanimity factor, that's what we say to our members. Oh, this is bipartisan, bicameral, stakeholders across industry and associations and all sorts of stakeholders think it should be done, say it needs to be done. And then they say, okay, great, so why haven't you gotten it done yet? So I think it's just a matter of time and kind of getting it across the finish line. We've gotten small steps with reconciliation, and hopefully we can kind of get that December packet plus other things going later, and whatever your boss has next in line.
I would reiterate, don't forget about the commercial market, and employers and employees who are also hugely impacted by PBMs. When you're, and figuring out how to end the perverse incentives, and yeah, the reconciliation package, and so much more is needed. And one other thing is, PBMs are smart, unfortunately, or they have smart people there. Sorry, perhaps sneaky, what have you, and they're always trying to get ahead of the, upcoming regulations, and we have to be ready for that. And we're just gonna have to keep doing more. GPOs, we haven't really addressed them in all that they do and all the harms they're causing. So be ready to deal with that.
I was going to say ditto. And I also think that, in a lot of areas of contention, this is an area that, it will have an immediate impact. People will be able to see this very quickly, the benefit. So I think that lends itself to a more positive approach to talking about healthcare policy changes that are on the cusp, but that really do need support to move across the table. I also echo, don't forget about the commercial market, because I would be remiss if saying most people living with MS are working age. So the commercial market is vital for them. And I think the other thing around this is to, again, to the rapidly changing nature of the healthcare system in the United States. Just making sure that people realize that this is a marathon, not a sprint. So, again, the next set of priorities, but just the also the need to kind of come back and reassess, what did we learn? What has changed in the market, and how are we keeping patients at the center of this in a real meaningful way as we move the conversation forward?
Well, thank you to all of our panelists for what's probably the most bipartisan, optimistic, evidence-based, and forward-looking healthcare thing happening today. Certainly over the past 20 minutes.
Thank you again. What? And
Thank you, Connor, and to the rest of the panel. And I want to give a special shout out to Leslie River. Yes, Leslie. And thank you. So that was a remarkable panel, and I just want to say thank you again to that powerhouse panel that led a really great discussion. Like Connor said, a very bipartisan issue, and I think that's a great way for us to end our summit on a very positive note about the possibilities that we can do together as a patient advocacy and caregiver community with respect to finding forward-thinking, common sense, practical solutions to really help support affordability and access for all patients. And so with that, what I want to say is to our panelists and moderators, thank you so much for your time today and for bringing your expertise, your candor, and your heart to these discussions. You didn't just share your knowledge, but you helped us see new possibilities. And to everyone here today, I want to say thank you once again for showing up, curiosity, and commitment, and asking some really great questions.